practice at all, since the majority of those who want to keep some sort of license but not practice would choose to have an exempt or an inactive because they're less expensive fee-wise, and you don't have to keep liability insurance. So those are the numbers of psychiatrists in Kansas. The next bullet point was some information that the Department of Children and Families tracks in regards to foster care, youth, and educational outcomes. So I know this committee, we've talked a lot about data and tracking that data. So we provided some of the data points that are supposed to be tracked for the governor's report card, Executive Order 2053, that was issued in June. That is obviously just issued in June, so we don't have the data collected on that yet, but that's in process. But the representative went ahead and also provided halfway down on page 2, some of these educational measurements that DCF tracks. And so on the electronic version of this, all of those are hyperlinked if you want to see them, but we do have some main bullet points, like the number and percentage of foster care youth ending their time in state custody who have completed the 12th grade, the number and percentage of children in out-of-home placement who will progress to the next grade level, the number and percentage of foster youth over the age of 6 attending the same school as prior to entering state custody. And so all that is linked there. And then we also have some health and social measurements, including the number and percentage of foster youth placed in out-of-home placements who are in a family-like setting, the number and percentage of foster youth who live with relatives while in out-of-home placement, and a couple of other measurements in there. So we wanted to provide those data points for you to show what DCF tracks. This isn't a comprehensive list, and we've included the link to find further data points that they tracked, but we want to include some of them to get you an idea of what the DCF is looking at. And then in that last data point under DCF, they did talk about how some other information is tracked in the review by the federal government. And that's what that attachment is to this memo, is some of the metrics that the federal government uses to review Kansas and all states' social welfare programs. And then lastly, in our last meeting, we talked a lot about the Juvenile Justice Oversight Committee and a lot about the funding and the different programs of that committee. So we've provided some information from one of our fiscal analysts about the JJOC. So the committee receives, the JJOC receives administrative assistance from KDOC, and they make recommendations to the Secretary of Corrections regarding expenditures from the Evidence-Based Juvenile Programs account. The representative from the JJOC explained that a little bit at our last meeting. And so the EBJP is the Evidence-Based Juvenile Programs account is administered by KDOC and is intended to support evidence-based community programs for juvenile offenders, juveniles experiencing mental health crisis, and their families. And then lastly, we've provided the expenditures chart on the last page of the memo from the Evidence-Based Juvenile Programs account. And so you can see some of the programs that are funded there and their estimates for the coming fiscal years. And I can take any questions.
Thank you, Marissa. On the, as you started on the DCF, I take it that these are all separate reports. It's not compiled like in one report.
I think there is a compile of one report, but they've separated some of them out so you can just see those metrics.
So you're saying that, okay, they have all of these items, but there may be some others in this big report, but these are their main items.
Yes, this isn't a comprehensive list of everything they tracked. We just wanted to get some examples of what they're tracking, and they provided the links to those data points.
So I guess what I'd like to find out is if it's possible to get, because I think these points here are spot on. If there was some way to compile those into a report, it's kind of like when we deal with the K-12 mental health pilot report. You know, we have the 10 or 12, I never remember the number because we've had to tweak a little bit, items, and we can sit and look at a report. And then if we need to dive down into details, there's another report to go to.
Okay, yeah, I can ask them if they have this in a more comprehensive document for you.
All right. Any questions, Representative Arnberger?
Thank you, Madam Chair. I'm looking at the expenditures from the Evidence-Based Juvenile Programs account. And this is the first time I've looked at this, so I have a couple questions. The first one, fourth from the bottom, the Microsoft Youth Offender Software. the actual in 2020 is 4.6 million, but the estimate for future years is 2 million. The reason why that is going down, or what is it, one, and why did it go down?
Yeah, so I, off the top of my head, would not know, but I can definitely find that information for you and try and figure out why there's 4 million of the actual in FY 2020 and what the reason they decreased their request on that program, and essentially find out what that program does.
Okay, and the second question I have is the parent project. It's another one that in actual, it's $158,000, and future years it's $50,000. And I think, I mean, again, I don't know what it is. I'm just curious on it, but those are the two. And then also other, what is other?
Yeah, I can find those for you. Thank you.
Representative Lynn.
Thank you, Madam Chair. On the educational measurements of the youth, I am curious to know how accurate that is as far as how many of the lost youth are in the system. Especially when we're looking at how many have completed 12th grade, are they including at least an acknowledgement that some of them were never tracked?
I can ask DCF to respond to that.
Further questions, comments, anyone on Zoom? All right, thank you very much, Melissa. And now we get to start with the fun stuff. So we're going to start the review of the working group report recommendations. And I believe that we have Hannah Shaw reporting in on that.
Good morning, Madam Chair. This is Hina Shah. I'm a senior analyst at the Kansas Health
Oh,
Institute.
we cannot hear you. Try it again.
Good morning. This is Hina Shah.
No, just wait just a moment. We can kind of hear you, but there's a volume issue and staff's coming in to take care of it. We're going to learn to work through the bugs. It's just going to be part of this learning curve and process that we have to deal with.
Okay, Hina, try again.
Good morning. This is Hina Shah.
Okay, any better?
Good morning.
Kind of faint. Okay, I think you can go, Hina.
Good morning. This is Hina Shah. Can you hear me?
Hold on just a moment. We can kind of hear you better, but we're also getting some major feedback.
I'm going to go ahead and ask Carly Houchin, my colleague, to present and pop in some earbuds if that will help.
Hey, good morning, everyone. This is Carly Houchin. How's my sound?
Well, we can hear you a little bit better. They're still trying to work on it on our end, Carly. So
Sounds good. I'll take just a minute then.
She may need you to talk a little bit to make it happen.
Carly, can I go ahead and get you to say a couple of things? Go ahead.
Good morning, everyone. This is Carly Houchin.
Okay, we can hear you, Carly.
All right, great. Well, once again, good morning, Chair Landwehr and members of the special committee. My name is Carly Houchin. I am a senior analyst at the Kansas Health Institute, and I, along with a team of my KHI colleagues, have provided facilitation support and report development to the working groups established by this committee. Briefly here this morning, I would like to provide a brief overview of the work done by those groups and an orientation to the working group product that you have received in advance of this meeting. Then the bulk of our time here today will be spent hearing from a wide variety of the working group members as to the different high priority recommendations and other items included in this final product. I will be speaking directly from the working group product and will do my best to orient you with page numbers as we move through the document. So first, I would like to provide a brief overview of the report components so that you'll be able to navigate the report easily over the course of the day as folks make reference to it. So first, I'm referring to the product that is titled a Strategic Framework for Modernizing the Kansas Behavioral Health System. And important to note right off the bat that throughout the development of this product, the working group discussed that this should be considered a living document to support ongoing collaboration between the many contributing partners in the behavioral health system, including both the government agencies and the state legislature. So this document is intended to provide long-term strategic direction for the modernization of the behavioral health system in our state. So as we get into the report here, one of the first things you should see is a table of contents, and that begins on Roman numeral page 1 of the report. And this really outlines the overall structure of each of the sections included there. Generally speaking, I'll say the report has some front material, the body of the report, and then a handful of appendices, and I'll walk you through what you can find in each of those here briefly. So the front material of the report includes a brief report overview, the table of high priority recommendation or high priority items from the working groups for the special committee consideration. The report, the front matter also includes a brief introduction that describes some of the relevant context in which this report was developed, as well as the working group process. And then lastly, in that kind of front section of the report is a brief data profile. So my colleague Hina Shah will provide a more detailed description of that data profile in just a few minutes. But at the highest level, it was included due to interest from this committee to identify measures or data sources that should show progress towards modernization as recommendations begin to be implemented. So then I'd like to direct your attention to the report overview. And so that begins on Roman numeral page 3 of the report, and would like to specifically highlight 2 components there for your particular attention. So first, per request, we have included a definition of behavioral health. So that definition was identified in collaboration with the state agency and was slightly adapted from SAMHSA. And so that reads, the behavioral health system refers to the system of care that includes the promotion of mental health, resilience, and well-being, the prevention, referral, diagnosis, and treatment of mental and substance use disorders, and the support of persons with lived experiences in recovery from these conditions, along with their families and communities. Then the second item in the report overview to direct your attention to on Roman numerals pages 4 and 5, we have drafted brief vision statements for modernization related to the 10 topics addressed in this report. So these vision statements are based on input from this committee, from discussion at some of your past meetings, as well as discussion in the 3 working groups. Throughout the body of the report, there are specific recommendations for the changes needed to modernize the behavioral health system, but these vision statements begin to define essentially what we mean by a modernized behavioral health system. So we know what change we are working towards with the more detailed recommendations that we will describe over the course of today. So then the body of the report begins on page 7. And the body of the report is broken out by working group. So those are the 3 working groups that the special committee established, which is the Finance and Sustainability Working Group, the Policy and Treatment Working Group, and the System Capacity and Transformation Working Group. And then within those, the report is broken out by the 10 topics assigned out to each of those groups. So related to each of those topics then, there are up to 5 high priority items or recommendations. Each of those high priority recommendations are then labeled either immediate action or strategic importance. So items for immediate action are those that the working group believes can be completed in the next 2 years. Then those of strategic importance are ones where work should start in the near term, but we will be able to complete those and begin to see outcomes and impact in the longer term. In addition to those 2 categories of recommendations, the working group also indicated 1 item, Medicaid expansion, as a high priority discussion item for this special committee. So then the body of the report includes a more detailed description of the high priority items from the Finance and Sustainability Working Group, addressing the topics assigned to them, which were workforce, funding and accessibility, and community engagement. Then the high priority recommendations from the policy and treatment working group related to their topics, which were treatment and recovery, prevention and education, and special populations. And then the system capacity and transformation working group and their high priority recommendations related to the topics assigned to them, which were.
I'm sorry, just a moment. Representative Ballard has a question.
Sure.
No, I thought she did. Go ahead. Never mind. You're fine.
Okay, I'll keep chugging along here. So then there's the system capacity and transformation working group, and they have high priority recommendations related to the topics of data systems, interactions with the legal system and law enforcement, and then system transformation. Then the last component in the body of the report is the high priority recommendations from the subgroup. So it had members from each of the 3 working groups that I've just described, and they convened to address the topic of telehealth. So then items that were not considered high priority, those were maintained for future work as opportunity allows in Appendix A of the report. And then other appendices included a copy of the recommendation rubric. So this rubric includes the dimensions by which the working groups discussed, scored, and then ultimately prioritized recommendations. And that can be found in Appendix B. Then Appendix C is 2 tables. So the immediate action and then strategic importance high priority recommendations. Appendix C has those 2 tables broken out by topic. So we included that for a couple of different reasons. There's maybe 2 ways you could use that table if you're interested to do so. One, it could be considered a checklist. So you could check items off as recommendations are implemented or move forward. Or secondly, in the electronic version of the report, those are hyperlinked and will allow you to navigate from that recommendation topic directly to the section of the report where it's described in more detail. Then Appendix D includes the list of special committee and working group members. So really this is just an extension of the acknowledgement sections of the front of the report, and really here would just like to highlight the really extensive list of individuals and organizations that have contributed to this work. The product in front of you would not have been possible without their expertise and time commitment. That being said, as this report's considered a living document, in that we attempt to recognize, the ongoing importance of both continued and expanded collaboration. So next, want to briefly highlight just a few components of the working group process so you can get a sense of how this product in front of you was developed. Again, really just wanting to highlight the extent to which a wide variety of individuals and organizations collaborated to make this product possible. So this process is described on pages 1 through 3 of the report, but I'll just briefly flag a couple of high points for you here. So the 3 working groups and then the telehealth subgroup met for a combined total of, I believe, 23 times for about 90 minutes per meeting. So when you think about the number of individuals attending each of those meetings, we're looking at a product in front of us here of several hundred hours of collaboration, which is very exciting. At each of the meetings, the working groups addressed one of the 10 topics assigned to them by the special committee. So figure 2 on page 3 of the report lists both the meeting dates and the topic covered, just for your reference. In addition to the working group members themselves, the working groups also identified those with additional or supplemental expertise related to each of the assigned topics, and then those individuals were invited to the meeting on that topic. Then throughout this process, the working groups operated by consensus. So we talked around and around on an issue until we found some common ground there. And then to arrive at the high priority recommendations in front of you today, the working groups all began with the recommendations from 5 previous collaborative efforts. So those were, just as a reminder, the Child Welfare System Task Force, the 2018 Governor's Substance Use Disorder Task Force, the Governor's Behavioral Health Services Planning Council, the Crossover Youth Working Group, and then both the 2018 and 2019 Mental Health Task Forces. So as far as process, for each of the recommendations from those past efforts, the working groups asked the question, is this recommendation an important part of what it would take to have a modernized behavioral health system? When the answer to that question was no, the recommendation was removed. And when the answer to that question was yes, the recommendation language was updated if needed, and it was scored. So to ensure consistency across working groups, all three of them used the same recommendation rubric that I briefly referenced previously. And again, that recommendation rubric can be found in Appendix B of the report in front of you. So the recommendations were scored using the recommendation rubric to arrive at both an ease of implementation as well as a potential for high impact score. These scores consider a number of items, such as the extent to which cost would be expected to be a barrier to implementation, as well as any potential for cost savings. The rubric also lists the mechanism needed to implement the change. So if we would expect it to require a change to state statute or regulation, or if there might be a federal approval process involved. And then additionally, the scores considered if the recommendation would significantly impact any special populations. So some of those special populations that were considered included foster care, frontier, rural, and urban communities, individuals with limited English proficiency, low-income individuals, children, veterans, among others. Additionally, the rubrics prompted the group to make note when the recommendation would serve those who had been disproportionately impacted by an issue. Then after the recommendations were scored, each working group did kind of a final review to prioritize and check in on consensus related to each of the high priority recommendations in front of you. So first, the group reviewed those items that had scored highly based on the ease of implementation and potential for high impact scores, but noted that some important changes for modernization will not necessarily be easy to implement. So in this final review, the working groups identified the high priority recommendations and labeled them either ones for immediate action or strategic importance. And those are defined in the body of the report or in the front portion of the report as well. Okay, so I think that concludes a really brief summary here on kind of the structure of the report in front of you and the working group process. Coming up in just a bit, you'll hear more from my colleague, Hina Shah, on the data profile, and then we'll begin to hear from working group members on their specific recommendations. For now, though, I'm happy to take any questions that you might have about either the structure of the report in front of you or on the working group process.
Committee, are there questions? Carla? Anyone on Zoom? All right, let's proceed forward.
Great. Hina?
Thank you. Good morning, Madam Chair. Is the sound better now?
Yes, it does. Thank you very much. And you might,
Terrific.
everyone needs to make sure as we go through this report, it's always helpful because sometimes we're also dealing with other distractions, is identify the pages periodically for us.
I can definitely do that. So again, good morning, Madam Chair, members of the special committee and working groups. My name's Hina Shah, and I'm a senior analyst at the Kansas Health Institute. And so as Carly mentioned this morning, I'm going to briefly discuss the data profile provided in the strategic framework, and I'm going to orient you to page 4 is where I will begin. So as Carly mentioned, during the special committee meetings, it was really discussed that there was a value of looking at data and monitoring outcomes. And so KHI convened 2 meetings with state agency staff only, and these were representatives from the working groups, and we also invited staff from the Kansas Department of Corrections and the Kansas Attorney General's office. What this group did is they looked at measures that are already collected by the state agency and identified those that could be put together as a really high-level data profile. And this would provide a systemic assessment of the state's behavioral health system. That's what you see on the following page as figure 3. And one thing to remember is this only includes a subset of a wide range of data that are available. So it's just a fragment of the data. These were the measures that kind of bubbled up to say what can really show, a systemic assessment of or the health of our behavioral health system. The second place that you'll find some measures are actually in the recommendations when you go to look at the recommendations in the rubric provided there. And again, these are just some measures that are collected by the state agency staff. By no means are these the only measures that would be required to measure impact for the recommendation. This is a starting point so that as this is a living document, you could start from here and then think of other measures to really measure the impact of that recommendation if implemented. So now I'm going to go to the following page, figure 3. And so aside from treating this as a living document and thinking about the number of recommendations that move forward and are implemented, and then really looking at the ones that were implemented with the identified key collaborators, a few other process measures that bubbled up to the top were the Kansas counties recognized as mental health professional shortage areas. This is a rubric that is available annually. And so there is past data available. And another way that it could be used in the future as a living document is to really think about the population that's living in each of these, what's called a HIPSA. Next, we have the counties served by mobile response and stabilization services, and also the counties served by crisis intervention centers. So the reason there's an asterisk there is there is data available and the state agency can provide it if this is a piece of data that the legislature would like to continue receiving. I would like to orient you to when you see the measure, there's a little italic note on the bottom of it that's to really gauge you to what the number means, whether the number, if lower is better or if higher is better, because it does change as you go from measure to measure. So then we have a set of outcome measures, and this is around uninsured rates to think about access. It's around the statewide age-adjusted mortality rate for suicide per 100,000 population. We also have highlighted the high school students, and so looking at youth and clinical indicators of depression. There's also the percent of children ages 3 to 17 with a mental health behavioral condition who receive treatment or counseling over time. And just so you know, for each of these outcome measures, we present the current year of data available and a previous year of data available for both Kansas and the US. You can use the previous year of Kansas as a comparison and also use the US measure as a benchmark, so that data is available that way. And in parentheses, we have provided the year because all of the data years are different. And so that will give you an idea of when that data was collected. And so the last 3 measures in that section have to do with individuals with SPMI that have been enrolled in supportive housing or supportive enrollment and have not had an ER or psychiatric hospital admission in the last 12 months. And then the very last outcome measure in this section is a long-term measure. It's a percent of individuals with inpatient psychiatric stay in the previous year that have returned to and remain in the community without additional hospitalizations. Right now, the agency would not be able to report this if there are certain recommendations related to data interoperability and higher rates of participation with health information exchanges, so the HIEs. This could be a reportable measure in the future. So that's the outcome measures section. Then I'll move on to the Mental Health in America rankings. And this is a ranking of the 50 states and Washington, D.C. by report year. The baseline report year is 2015. And what, yes.
Okay, we have a question, Senator Payne.
Sure.
You were talking about the outcome. Sorry. You were talking about the outcome measures under the last 2 under figure 3. And so are you saying that because there's asterisks there. So they're there because if we determine to gather that information in the future.
So I think I'm having a little difficulty hearing, but what I'm hearing is, so if there's a single asterisk, this data is reportable by a state agency. So if this is a data point of interest, the state agency can report it. If there's a double asterisk, what this means is that at this time, this measure isn't reportable because we do need some recommendations that have been high priority by this working group to be implemented. So there does need to be some higher participation in HIEs and also a little bit of data interoperability to be able to pull this data. So that's just that last one.
Thanks.
Is that helpful?
Yes.
Okay. All right, and then the last section is a set of rankings. And so these rankings use national data from surveys such as the National Survey on Drug Use and Health, also known as NSDUH, and the Behavioral Risk Factor Surveillance System, known as BRFIS. Also, it pulls from the National Center for Education Statistics, County Health Rankings, and a few others. And so the rank itself is comprised of 15 measures for adults and youth. And these are around mental health issues, substance use issues, access to insurance, access to adequate insurance, as well as access to and barriers to accessing mental health care. And so when you look at the ranks, a rank of about 1 to 13 indicates lower prevalence of mental illness and higher rates of access to care. And then the higher ones show the opposite. So states that have a really positive outcome are ranked closer to 1. And then the poorer outcomes are higher, closer to 51. And then the way that the reporting year, so the data reported, we don't have the parentheses here. So the way to look at it is for the 2021 report, that data is from 2017 to 2018. And then the 2020 report includes data from 2016 to 2017. And then you can think of it as a pattern through, again, with the baseline year of 2015. And so that's the data profile section. Any questions on the rankings?
Representative Carpenter?
Thank you, Madam Chair. On this ranking here, so we ranked in 2021, we ranked dead last in adults with mental illness who report unmet needs.
Yes.
Representative Harnberger?
Thank you, Madam Chair. My question, I didn't know if you wanted to wait till the very end or not, but my question actually is on page 5, at the very top where it says Kansas County is recognized for the mental health professional shortage area. There's 99. I'm just curious, what are the 6 that are not recognized?
They're the ones kind of in the Northeast. So Johnson County, let me pull up the map. Actually, if you have an electronic version, you can press on the blue there and you can see it, but it's Johnson, Wyandotte, Miami, Franklin, Douglas, and Shawnee counties.
Okay, thank you.
And I think you brought up when you mentioned the hyperlink in there, I think that's an important piece is the digital version is going to be much more useful on information because of the hyperlinks to take you into other areas. So thank you for mentioning that. Representative Lynn.
Thank you, Madam Chair. I'm looking at the mental health rankings. Do you have any information on why 2020 seems to be significantly worse than all of the other years around it? Was there a general reason for that?
I am going to see if Kelsey is on, if she wants to speak to that, but I will say that it is a set of 15 measures that they use and you are being ranked against other states. But Kelsey, if you want to speak more to maybe why the changes happen over time.
Hey, this is Kelsey with KDHE. I am not sure about that either. This is Mental Health America data. So we'd have to really dig into the various reports to see if we can catch any kind of trend that might have happened between those or like change that happened between those 2 years, but I'm not immediately aware of anything that occurred.
It does seem to improve for 2021 with the exception of the one that Representative Carpenter pointed out. So I guess I'm kind of curious to why that one is kind of like an outlier.
Representative Carpenter, go ahead, let's make your comment public so we keep everyone in, because it was a good point.
And I just wonder if it's not some kind of glitch in the data. We went from 2019, 29, ranking 29th to 51 in 2021, which seems a little extreme. So I would be curious. I would like to see someone dig into that a little bit more, or just shoot me that information. I can try to decipher on my own. Thank you.
Okay, go ahead.
I don't know what's, so at 2015, we're at the number 51 as well.
Right.
And we can definitely take that question back to both the agency and also dig into it ourselves to see if we can give you a response.
Well, I think that one of the things, committee, that we're going to discover as we go through there is not new information, but now we've been able to take and compile all the different task force that we've had over the past few years and bring this information into one major report. And what you will see as we advance forward, I keep referring to it as a living report, and I'm driving legislative research crazy with that. But the goal will be, as you'll see, that we'll have check-off boxes and types of things in this report, which is unusual, in order for us to track what we do or do not take action on in future years. Now, that doesn't mean we don't tweak them, because every year something new, something changes, something evolves that may or may not be in this report. So hopefully this is a document that we utilize going forward. So the information we have in this report is pretty important. And that's why you see it the size that it is. Go ahead.
And one thing I will mention is that I can give you like the annual report for each of these that will break down each of the measures as well. So we can provide that to the committee from 2015 to 2021, the individual entire reports. Here we just consolidated the ranks for the purposes of showing what the trend is, but that may be helpful as well to look at the full report. So that is figure 3 of the data profile. And as Carly mentioned, as you will navigate through the report, so if you hop down to like page 9, you'll see under workforce recommendation 1.1, it says measuring impact, and there's a measure in there. I'd like to again reiterate that this is just one example of what state agencies are collecting, and by no means the only measure that would be measuring impact if this recommendation was implemented. This is just a starting point for future groups to be able to start from, and then actually just, again, working into this living framework. And that is all I have. And I was going to turn it over to the work groups unless there are any more questions.
Any further questions, committee? Representative Glenn.
Thank you, Madam Chair. I'm still stuck on this health rankings, because I think it could mean two different things, the variation that we see. It's either that as Kansas, we're doing something wrong, or there are states that are doing something significantly right. And I guess I'd be curious to know if there are states that made a significant jump, and why did they have that success? What were they doing right? Thank you.
That's a very good point. And again, the whole report and for all 50 states is available on their website. And so we can definitely provide a little more information. Would you be interested in the neighboring states or certain states, just so I can orient myself?
Thank you, Madam Chair. I would say either, I would say that as well as any states that made significant changes.
Okay.
Representative Carpenter.
Thank you, Madam Chair. I would just like to see the ones that have asterisks that we have that information on filled in.
Now, if I recall correctly, Hannah, what we discovered with the one asterisk was that the information is available, but perhaps it's not in a reportable form. Is that correct?
With the one asterisk, they are available. I think we just need to give the state agency a little more time to pull that data. And with a double asterisk, we do need to wait for implementation of certain recommendations.
So what we may want to give consideration to, Representative Carpenter, is looking at, so the data is out there, but it's not necessarily in a reportable format. So what format and what information would we want? How would we want that reported? So that they hold that as a specific report. Does that, and you don't need to answer that right now. We can go back and get that, but it's just not in one report.
I don't, maybe not disagree with you, but I think counties served by crisis intervention centers is a pretty easy one.
Okay.
You know, just show me the statewide report and I'll figure that one out.
Right.
Okay.
No, that's fine. I just wanted to be very specific.
Right.
On what
I understand.
you're right on the mark.
Okay, thank you.
Senator Penn.
So if we're looking for specific bullet points, I would also ask that those states that whether they have passed Medicaid expansion or not.
That's fine. Even though the senator and I are on opposite sides of that issue, we will be happy to gather that information. Committee, are there further questions? Anyone on Zoom?
And Madam Chair, could I defer to Andy Brown for the county served by crisis intervention centers? I believe that data isn't available at this point because they are still working on implementing or getting those centers up and running.
Yeah, so this is Andy Brown with ks.gov, and just as an update on that particular measure, we currently do not have any licensed CICs in Kansas. We're still working on propagating the regs for that. I anticipate we'll have the regs out soon, and we'll probably have our first initial CICs operating probably sometime next year. I think Douglas County is planning on being online about this time next year. And I think RSI is probably likely to be the other initial CIC that operates. So those two should be probably up and running by the end of next year. But right now the answer would be 0. We have 0 counties that are served by CICs.
Okay, and now you've got us confused because I believe we do have some crisis centers already in place. And one thing, Andy, I ask is there's some, don't do it right now, but when we're done with you, is there some glare coming from your windows in the back?
Oh. See if that helps at all. But so, yeah, just to clarify, what we have right now essentially are crisis stabilization units. Which are referred to sometimes as crisis centers. But in terms of our statutory authority for licensing crisis intervention centers, which are the CICs, we have not licensed any facilities as a CIC in Kansas as of today.
So we need to make sure that in our report that we clarify that, because that's where Representative Carpenter and I are confused with this.
Yeah.
So we talked about this as we've gone through different work groups is the terminology we use, but what is a more accurate way to describe that?
Yeah.
So I guess KHI, we need to anywhere that we see that in this report, we need to clarify that definition of what is today and what will be tomorrow. Is that
Madam Chairman, this is Representative Elizabeth Bishop, and as you might imagine, I'm very interested in this as well. Not realizing that there were different definitions, I would appreciate an explanation of the definitions of a crisis stabilization unit as opposed to a CIC, and what that means in terms of funding. Why is an actual regulations to be developed for a CIC necessary? What issue is it resolving or solving?
Well, I think, Bishop, you kind of hit the nail on the head because those are very good questions. So we need to, whether, and I don't know, that's probably either with the agency that Andy can help us to come back to us with perhaps later on today, or for our legislative research staff to assist in clarifying that, because there is a big difference. So what are those terms? Why are they different? And does funding make a difference? Because there's no sense in jumping through a hoop if we don't have to jump through a hoop. Senator Payne.
So I believe again, I like to give us a definition right now. I think we have to find.
Yeah. So Madam Chair.
No, I think, Andy, just a moment. No, and I think Andy can verbally give that to us. I'm not concerned about that. But Andy needs to give that to us in writing so that we clarify that in our report. So that as we move forward, that we're all dealing with the same terminology and know exactly what it is that we're authorizing or not authorizing in the future. Because funding will be needed for some of these programs. Does that make sense? Okay. So Andy, you want to put something together in writing for us? And that will save our staff so that, say, okay, this is the term we're using today, but this is what that means. This is the term that we would use tomorrow if we wanted to license them, and this is what that would mean. And how would the funding structure work?
Yeah, and Madam Chair, I'd be happy to do that. I will point out that the CIC definition, or the Crisis Intervention Center definition, is a statutory definition. So I can track down the reference for that and provide that, but it's defined in statute.
Right. Okay, then maybe we'll hand that to Eileen. If you could put that together for us, we can. Okay, we'll have our revisor do that, Andy.
Terrific.
That's fine, just so that we're all going forward on the same page. Because I think what we've been in these working groups is trying to be really detailed on what does this statement mean when we use a term. That's why we discussed a lot about what does behavioral health mean versus mental health.
Yeah.
So, Representative Carpenter.
Thank you, Madam Chair. And Andy, also, when was that law passed and put in statutes? Would be a good question too.
I think Carpenter Eileen can bring that to us when she brings us the definitions.
Okay, super. Thank you.
Don't be afraid to tell us no, Andy. I don't bite that much. Any other further questions right now, committee? All right, seeing none, please proceed, Nina.
One thing I wanted to mention about the CIC definition, when you go to recommendation 3.1, which will be presented by the working group, you will see definitions throughout in the recommendations, but it is in the body of the strategic framework and report. So as you go through each recommendation, you'll see it defined there. So with that, I was going to turn it over to our first working group on finance and sustainability and invite Greg Hennon to report on the workforce, and we'll go topic by topic. We'll give each topic about 30 minutes. So the working group representative will present the topic and the recommendations and then stand for questions, and then we'll move on to the next topic. So first, I'd like to invite Greg Hennon.
All right, thank you. Yes, I'm Greg Hennon with 4 County Mental Health Center. Thank you for the opportunity to be here, Madam Chair. I'll be talking about 5 recommendations that kind of percolated to the top of all of our discussions surrounding workforce. The first one can be found on page 8 of the documents. Recommendation 1.1 has to do with clinical supervision hours for postgraduate degree and licensed practitioners. So this affects people that have gone through their graduate training, have been conferred a degree, and enter the work field with a license from Behavioral Sciences Regulatory Board. Then they can begin getting supervision hours accrued toward what is called clinical level licensure. So it may be a licensed master's level social worker. After they have X number of field experience hours as a working licensed professional, they can then sit for another exam and get a clinical level license, which allows for independent scope of practice, but also is important for Medicare reimbursement and so forth. So this recommendation is specific to reducing the number of clinical supervision hours required of that master's level clinician so that they can get their clinical licensure, reduce that from what is currently a policy of 4,000 post-degree supervision hours down to 3,000. That recommendation was enacted with the social work discipline back in 2019, and a couple of things came from that. One, it created kind of a level playing field, if you will. Our surrounding states require 3,000 post-degree supervision hours for that clinical level licensure. Kansas, being at 4,000, was at a disadvantage in being able to recruit and retain that workforce. So there's been some feedback that that change has already made a difference in recruitment for the social work discipline. And this recommendation is that for other master's level clinicians, which may be a degree in psychology or counseling, marriage and family therapy, etc., that all of those disciplines post-degree supervision also be reduced from 4,000 down to 3,000. I don't know if you want to wait for any questions or if I should stand for those now, or should I go to my next recommendation?
I think as we get each recommendation, we'll just see if there are questions so that we can get immediate responses. Are there any questions, committee? Seeing none, please proceed.
Okay, thank you. Also on page 8, you'll find recommendation 1.2. This has to do with access to psychiatry services. And the recommendation is carried over for some other work group recommendations, but for a study to be conducted by KDHE and an educational institution to explore strategies to increase the number of psychiatrists, child and adolescent psychiatrists, and psychiatric nurses in the state. We heard just a little bit ago about the health professional shortage areas and how many licensed psychiatrists we have in the state. There's an estimation that it would take another 54, and I believe the number was 473 or something like that in the state right now that are licensed. It'd take another 54 on top of that for all of the regions in Kansas to no longer be a health professional shortage area where that psychiatry need is in play. So to be able to conduct a study to find some strategies to increase that is one that, again, percolated to the top of our recommendations because so many of us have been trying to recruit psychiatrists for literally years and can't get an applicant. So that workforce really does need to be developed. Again, I'll pause for any questions.
Any questions for the committee members? Representative Lynn.
Okay. Oh, sorry.
We do have a question, Representative Lynn.
Thank you, Madam Chair. I'm on this workforce, but I don't remember if we discussed necessarily which educational institution, or is that something that KDHE will decide? And if we'll be looking at, I'm guessing the larger ones, but also I'm wondering if we'll look at some of the smaller institutions that also offer these classes.
Yeah, my recollection is consistent with yours that there was not an educational institution recommended, and that would be something KDHE would decide on. And then I could not hear the second part of your question, so I'm sorry I missed that.
I was just asking if we will be looking at not only the larger institutions, but some of the smaller ones that might have other insight.
Right.
Well, and I think that, we talk about KDHE having the ability to determine where is that language could be put in there, that it should be open to all that provide these these classes, and we can clarify that rather than giving it to the agency. So, Carly and Nina, is it better for us to make some of these changes as we go through this, or would you rather us gather those and then do them all at once?
I think you could do it either way, whichever is easiest for you, and then we can make the updates with Melissa and Marissa.
Okay, let's make them as we go through. I think that'll be easier than trying to, flip back later. So, staff, do you understand what we're looking for? So we don't give that authority to the agency, is that it's open to all the schools that provide that education. All right, staff will work on that and get it back to you. If anyone on the working group has got input that they would like to, add on changes as we go through this, please feel free to speak up. This isn't just about legislature. Senator Petty.
Thank you, Madam Chair. I guess maybe I got off track here, but I thought this, if we're on access to psychiatric services, and I thought we were talking about talks about a study to be conducted. Are we done on that? Did I get off track here? I mean, it's not who, it's a study that a institution would do a study.
It's kind of a combination of both. I think it's the committee saying that you don't have to just look at our big universities. There may be another university, so they should look at anyone that we have out there that might be capable. Sometimes we just go to our big 3 or 4 and forget that we have a lot of other universities that have as good of ability to do it. So
To do a study?
Mhm.
This is a study,
Mhm.
not studies. I'm trying to clarify. Does the work group talk about a study or studies? There's a difference.
What was the discussion?
This is Will.
Yeah, go ahead, Will.
Oh yeah, this is Will Warrens. I think the reason why study was put in the language is because this is a long time problem with physicians, well known, not even in psychiatry, but all physicians. When I became a family practitioner in Nebraska, this was a big problem there, getting family practitioners out to rural areas. And that was 15, almost 20 years ago. So I think so many attempts have been made to be successful in increasing physicians working in urban, rural, and frontier counties in various states, that I think the work group felt it might be presumptuous for us to advocate for a specific way that should happen, because the last thing we wanted to do is to create a program that would be ineffective and end up being a waste of the money and resources that are put into it. So we checked it back to a study to just try to examine the problem before we had more specific recommendations of how to solve that problem.
Okay, Will, you may want to either pull that line down behind you or shift gears a little bit because you're just a little bright on one side there. We can't necessarily see.
Sure, no problem.
All right, Senator Petty, and then Valerie.
And thank you, Madam Chair. So I noticed that this recommendation of a study was originally developed by the Mental Health Task Force. So is that the same recommendation? Or is this is just reiterating what came out from the Mental Health Task Force? That's referenced here in the rationale.
This is Will Warrens again. My understanding is that the desire to address the issue came from the Mental Health Task Force, but I think there were other elements such as the incorporation of the Kansas State Loan Repayment Program, trying to analyze that program, in addition to the desire of the Mental Health Task Force. So I don't think they're exactly identical.
Thank you. Representative Valerie.
Thank you, Madam Chair. I would concur with Will. And usually when you can use the terminology a study. A study can actually have 3, 4, or more studies within it, but it's a study of looking at these issues. So it's not like a study meaning only one. But yes, it was taken from the task force because sometimes we talked about their recommendations, but we had a conversation about how difficult it is to get a psychiatrist. I use the example of Bert Nash. We have a very large community mental health thing, and yet it took us over 3 years to find a psychiatrist. And as a result of that, you know, it becomes different. Now, our psychiatrist actually is housed, or he is, in Kansas City, but he comes in and he's doing this. So part of that study was, is it, we're not paying enough? You know, are we asking them to do too much without backup staff or whatever? So you would look in various places for what that study might be, and that's what you would be reporting on.
Representative Bishop, and then I'll come back to Representative Lynn.
Thank you, Madam Chair. I would just like to point out that the state of Nebraska just recently, and in the last, I think, 3 years, conducted a considerable study into the shortage of mental health professionals across the board. And I recognize the special need for psychiatric professionals and understand why this issue, this particular part of the whole picture needs to be addressed, but I think we should also be looking at the other levels of mental health professionals that are also in short supply and possibly do an across the board study.
Representative Lynn.
Thank you, Madam Chair. The way I read it was that a study would be conducted by KDHE that I think should include multiple institutions who might have other insight. So that's kind of how I read it, is that it would be one study, just making sure they have multiple sources so they can get all those ideas, whether it be, you know, just the psychiatrists or other professionals, just like the counselors as well.
Further questions, further comments? All right, Greg, you may proceed.
Okay, thank you. And I don't know if I mentioned this, the first two recommendations that we've spoken about, the clinical supervision hours and the access to psychiatry services, that study for access, were part of recommendations we believe needed immediate action. And Carly had pointed out that the immediate action recommendations were those that were felt could be done in 1 to 2 years. The third of our immediate action recommendations as it relates to workforce has to do with provider MAT training. That's medication assisted treatment training. And this is a specialty training for prescribers in the treatment of opioid abuse or use disorders. You'll find the longer explanation on page 9. But really what we're looking for there is for resources to be put forward so that more prescribing practitioners would have expertise in MAT, and that service be more widely available across several localities. We do some of this work at 4 County Mental Health Center across a 16 county region. But we only have a handful of providers that are qualified to do that work. So it does right now involve some travel for some people in order to get to a provider to do that. So this recommendation would provide some funding for increased training so that that certification or within their scope of practice could be met, and more MAT treatment available to those in need. Any questions regarding that recommendation?
Any questions? Seeing none, proceed.
Okay, the last two that I'm going to speak about were recommendations that were identified as having strategic importance. And that was something that probably has a longer term or a longer turnaround than just a 1 or 2 year type of implementation. But on page 10, you'll see a recommendation for a workforce investment plan. And there, we believe the state of Kansas should make a long-term investment for behavioral health system workforce by increasing funding for training, recruitment, retention, and support of highly qualified staff. And there are really a couple of points to this recommendation. One was the development of an associate degree level credential where people could kind of get their introduction to the behavioral health field. And if they attended one of the community colleges and got an associate's degree, they would be eligible for a job within the behavioral health system. I know we've got a licensed mental health technician credential that's out there. Maybe the state hospitals use those. But what was noted in our discussion is that there isn't a specified curriculum or training program at the associate's level. And if there were something like that where people could enter the workforce and get some experience, they would have opportunity to then complete a bachelor's and do case management work, and that may prompt them to seek a master's degree and become a therapist. It would just create a ladder for that workforce development. So the other point that was brought out is that by having kind of that broader opportunity to enter into the behavioral health workforce and get that experience, we may do a better job of increasing workforce diversity. And that was an important point that came forward in terms of our perception of how the workforce needs to develop across the state. I'll pause for any question there.
Questions, committee members? Anyone on Zoom?
Yeah, this is Will Warrens. I just want to follow up. There was some substantial talk in the work group about whether or not the topic of workforce diversity should be embedded within this recommendation. It actually was considered a pretty important topic, the diversity of the workforce. I'm just pointing that out, as far as we just hoped that it wouldn't get too buried or too lost by being merged with another recommendation. But we also were balancing trying to limit the amount of recommendations that were coming out of our workforce. So that's how we struck that balance there.
And the final recommendation on workforce can be found on page 11 of the report, and it's recommendation 1.5 surrounding family engagement practices. And the recommendation is that there be a provision of adequate workforce compensation and reimbursement rates for the time spent planning and implementing family engagement practices. Those are specific services. But the reimbursement rates were seen as being inadequate to really promote and enable that service to be delivered. This was a recommendation of the Children's Subcommittee of Governor's Behavioral Health Service Planning Council, but it was one that again came to the surface of this work group, believing that it would have a significant impact in supporting parents and families, and then of course benefit the children both at home and in school. So I'll stand for any questions there, or actually I would defer to the work group for any questions, because I'm not specifically familiar or got any expertise on that particular service.
Any further questions, comments?
This is Gary Hinault from KDADS. I was not on this particular work group, but was asked to be available for questions or make comments related to this particular recommendation. And I guess the thing that I would say most is that one of the things that we find is very significant but struggle to really maintain is that family involvement in getting families to the table when it comes to our youth. So much of the time we're focused on just treating the youth outside of the family unit, but we really need to make a concerted effort to meet the needs of the family as one of the most important parts of the treatment of youth. And family, I use that term broadly in the sense that this would mean biological family, foster family, or those adult individuals that are close to the child.
Well, Gary, you bring up a really good point in that, and that is it's one of the major pieces in the K-12 mental health pilot program, that to have true wraparound services, because you can't always just treat the child. It may be issues, the child dealing with issues subconsciously or whatever, that are things happening at home. And so they have the ability in that program then to engage the parents into it. One of the consequences that we never even thought about was in our small communities where you may be concerned about walking into a CMHC, so everybody knows that you've gone there, that now they can walk into that school building and receive those services and no one has any idea. So it has brought around the whole family unit, because maybe mom or dad has lost their job, or they're trying to figure out how to make bills, or they're needing groceries, or maybe it's healthcare. And how do we get for FQHC? So you bring up a very good point. It has to involve the family. Unfortunately, also what we have found out in this program, as I've gone around the state and visited with some of our different folks within that are operating this program, is the struggle sometimes to just get families to help us approve, to help these kids. And so we're figuring out ways to work with that, and they're getting very creative with it. But you brought up a very, very important point.
Thank you. And I agree. I can't agree more with the idea of meeting families where they're at, instead of, like meeting them at the school. Families are already there. But where, meeting the families where they're at instead of adding to the struggle that a lot of families have in gaining services.
I've just been reminded by my staff that everyone on that speaks on this, whether it's us in committee or on Zoom, is need to identify themselves, because that we are out there on in the public. No, we're all guilty of it, so including myself. Okay, proceed.
This is Greg with Fork County Mental Health, and that concludes my presentation of the workforce recommendations. And I believe Dr. Warrens is going to present on funding and accessibility.
This is Hina Shah from KHI. I'm going to interject for just 1 second, Greg. I wanted to orient the group back to the vision for workforce as you think through these tomorrow during your working day. It's at the top of every section and also in that front matter where the report overview is. But for workforce, the vision was a modernized workforce is one where behavioral health staffing is adequate to meet the needs across rural, frontier, and urban areas of the state. Telehealth will play a role in meeting needs, but local staffing remains important. Modernization will require both growing and retaining the workforce. So I just wanted everyone to keep that in mind, as this is a strategic framework as to the vision for these recommendations. And as Dr. Warrens now presents on funding and accessibility, starting out with that vision and then really going through the recommendations just to orient everyone. Thank you.
Yes, this is Will Warrens. So when it comes to funding and accessibility, the workforce very strongly advocated for, in a modernized behavioral health system, we should really be looking at the certified community behavioral health clinic model for its work in integrated care with mental health and physical health, for its acknowledgement of the work the difficulty that this work would create, and so the increased reimbursement rates, and then the following of its own quality measures. We felt like, for multiple reasons, it's a model that we can get behind, and therefore we made it our #1 recommendation, which I'll get to in a second. We also felt that accurate and appropriate funding for Kansans was important. It's going to be important for a sustainably funded system for the next 10 years. And there might have to be some work looking into that as far as how that is operating right now and what changes might have to be made. when it comes to funding. But anyways, recommendation number 2.1, certified community behavioral health clinic model. The group is and this is one that was tagged for immediate action. The group is recommending expansion of the Federal Excellence in Mental Health Act. So we heard some presentations on this. I believe SAMHSA gave a presentation, and we've talked about it multiple times that we would love to be able to participate in the Mental Health Act. The Mental Health Act was an act passed in 2014 that established CCBHC, Certified Community Behavioral Health Clinics. And you can see in the body, this is on page 12, where it talks about the elements that a CCBHC is obligated to provide: crisis mental health services, the integrated piece here, screening and assessment. Oh, no, sorry, it's coming, the integrated piece. But screening and assessment and diagnosis, patient-centered treatment planning, outpatient mental health and substance abuse services. Here's the integrated piece: outpatient clinic, primary care screening and monitoring of key health indicators, and some other elements as well that it takes to be certified at this level. I know that KDADS has done some advocating for Kansas to be considered for an expansion in the Excellence in Mental Health Act. If that were to happen, then we would be able to benefit statewide from the Excellence in Mental Health Act. Greg Hennon is kind of a local expert on the CCBHC model as well, because his center, Fork County Community Mental Health Center, has been awarded a grant to proceed towards becoming a CCBHC. And certainly we would advocate for any grants for other centers around the state. But barring that, we also would be very interested in pursuing a CCBHC model through a state plan amendment or change to Section 1115 waiver. And we had a presentation on October 30th given to us by a representative from Texas who outlined their experience with trying to pursue that type of a state model for the CCBHC system. We ranked the ease of implementation as a 5 and the potential for high impact as an 8. It would be a new program. Cost would be a barrier. And would require legislative session, federal approval process, a regulatory process, and budget development. However, it would impact a large population. And we purposefully positioned this recommendation as 2.1, so it would be our first recommendation in this section. So any questions about that recommendation?
Any questions, Representative Lynn?
Thank you, Madam Chair. This is Representative Lynn. If I may go back to the introduction of this section of the funding accessibility. I believe in the last work group meeting that we had, in the second paragraph, first sentence, we had removed the portion where it says who currently lack coverage. I think we wanted to make sure we included all Kansans and not just those who are currently.
What page are you on?
I'm sorry, I'm on page 11. It says appropriate funding of Kansans who currently lack coverage. I think we were taking out the currently lack coverage part.
Representative Ballard?
Yes, I concur with that, we understood that was important, and it's mentioned in another area, but we said that we would just say appropriate funding and of all Kansans along those lines. So we wanted to make sure it wasn't just specific for lack coverage, but all Kansans.
So what you're suggesting here is that between of and Kansans, we add the word all, remove who currently lack coverage. So then it reads, the working group asserted that accurate and appropriate funding of all Kansans is a key element of sustainability, funded, et cetera, et cetera, et cetera. Is that correct? Everyone in agreement? I don't plan on, as we make these changes, I don't plan on going into, doing full votes, that just takes up a lot of time, so I'll just be asking for agreement on it. So we're in agreement, and that's the change that will be made on that word.
What page? I beg your pardon, but what page are we on?
Who is this?
Representative Elizabeth Bishop, sorry.
That's fine. Page, Representative, it's on page 11, under funding and accessibility, second paragraph, towards the end of the first line.
Okay, hang on a second.
So you will insert the word all between of, Kansans, delete who currently lack coverage.
Sorry, this is Representative Elizabeth. I'm struggling with some vision issues. I need new glasses. I get them next week. Hallelujah. I don't see the area that you're referring to. I'm sorry. Which block is it in? It talks about suicide prevention.
No. Page 11. At the bottom, under the heading funding and accessibility.
This is Will Warrens. Representative Bishop, there are a couple different versions of this draft, and in a previous version on page 11, they do talk about suicide prevention. I don't know if that's part of the confusion.
That explains a lot. Thank you.
Thank you, Will. Okay, so Representative Bishop, you need to find the current version, which was sent out.
Oh, sorry, this is Will Warrens again. On that previous version, Representative Bishop, you might find it on page 10, down the page under funding and accessibility in the second block.
And Elizabeth Bishop, the staff is going to resend that to you, so you should get an email, and that may be one you want to open and operate off of.
Madam Chairman and Will, thank you so much. I will be watching for that because I don't find it on page 10 either.
Oh.
Okay. So once I get that, I'll be up to speed and I'll quit bothering you guys. Thank you so much.
All right. Well, this has gone through a lot of revisions. Representative Arnberger.
Thank you, Madam Chair. I just have a quick question on, you mentioned how cost would be a barrier. Do you have any idea on a fiscal note or if staff maybe came up with a fiscal note that we're looking at for that?
Are you on the CB?
Yep, I'm back on page 12.
Okay. What we currently know, and staff can chime in, and anyone else that's out there that may have more than what I've got, but there will be a cost incurred in order to create these CCBHCs. And I think the fiscal note is still kind of being determined because there's a couple of ways to go about it. We could go ahead and create that today, but we wouldn't get the enhanced federal match. And that's why the path that we will probably take to expedite, instead of just waiting on the feds to open up the, what they call that, the mental health, Excellence in Mental Health Act. If that doesn't get opened back up, which would be the easiest path, we are going to try to go through an 1115 waiver, which would give us something similar to what Texas put together. It's kind of a backdoor coming into it. It's not as great of a program, but the match is better than what we currently have. It's hard to determine what that fiscal will be today, but there will be a fiscal. It'll be the SGF portion. Did I explain that correctly? Staff, you have to fix me on that.
Yeah, this is Greg with Fort County. The concern about the potential cost being a barrier is if there were not federal capacity building grants available, such as the grant we were able to secure, or if the Excellence Act wasn't expanded, just like Representative Landwehr explained. However, with a state plan amendment or with an 1115 waiver adjustment, there can be built in a cost neutrality where over time, the improvements in health outcomes and the decreased health expense offsets the cost of having operated the CCBHC. The biggest issue is getting the programs kind of spun up from the beginning. So that's where the federal grant dollars are important for cost not to be an issue.
I should have gone to the expert in the first place, Greg. You did all this. Thank you. Bill, would you like to continue?
Yes, okay.
Make sure you
So,
so we're with you.
oh, let's see. Yes, sorry. So recommendation 2.2, this is addressing inpatient capacity. This is one that we've also tagged for immediate action. Implement and fund a comprehensive plan to address voluntary and involuntary hospital inpatient capacity. There was a focus on wanting to make this a regional model for the provision of inpatient mental health services. Highlight, and then I think some of the working group members, especially some that had extensive history in working in the state hospital system, wanted to make sure that this capacity would also incorporate or be able to handle the difficulty it takes working with these patients when they are in states that they are a significant danger to themselves and to others. I believe this is closely tied, this recommendation is also closely tied to a lot of work that is actually ongoing by KDADS in preparations for the passing of a state institutional alternative, which is going to be key to resolving the state moratorium on hospital beds, and is also going to try to be definitely focused on a regional model of how those beds are replaced in the state institutional alternative model. We gave it an ease of implementation score of 4 and a potential for high impact 8. And certainly this is a subject that creates a lot of attention because emergency rooms around the state are having to care for these individuals when they are not well equipped. I think they're well equipped in the short term, but they're not well equipped when the patient has to stay there for 1, 2, 3, 4 days of treatment when they really need a true hospital bed. Let's see. So yeah, I think that mostly sums up our thoughts on this recommendation.
Questions, comments on 2.2? I know that there were some concerns, and I think we reiterated on a regular basis that even though we talk about the potential addition of 1 or 2 more regional style hospitals, that does not mean in any way that we even looked at or considered the closing of Los Guadalupe. Because I know that some folks will, when they hear those discussions, they get concerned, but it's in addition to, not the closing, because we don't need to reduce any beds whatsoever. Any other further comments? Okay, let's go on to the next page.
Okay, recommendation 2.3. So part of this comes from a talk that was given to the committee by Keith Rickard on October 30th. He was trying to, I think, lay out for the committee some of the larger financial concerns that the CMHC system as a whole is dealing with. And I think that a lot of those concerns, plus COVID, has led them to a crisis situation. And so one of the recommendations was an increase of 10 to 15% for reimbursement rates for behavioral health services. I think this is another 2-part recommendation because in addition to that recommendation, I think there are substantial reasons for looking into how state grant funding levels are created and how reimbursement rates are set for CMHCs and how all these populations work together to finance a CMHC. And for those reasons, we are recommending a working group be created to look into some of these macroeconomic factors in the behavioral health realm. It's nice to see that in the 2020 legislative session, the final budget bill also included proviso requiring KDHE to complete a detailed review of costs and reimbursement rates. If this working group is created, then certainly that's going to be a very helpful information for the working group. I also think that a working group is a good vehicle to talk about something like this, because while if CCBHC gets adopted, that certainly can, I don't want to say a miracle or get out of jail free card, but I mean that certainly would help a lot in the funding structure for the CMHC system. And obviously Medicaid expansion would have substantial effects. But the purpose of this recommendation is to try to set up, what if those two things don't happen? You know, what if neither one of those things happen? What do we think about how the CMHCs are funded, and how can we, in a calm, level-headed way, maybe think about where they could be, how they could be funded, you know, over the next 10 years. And some of this, and not all of this has to do with just the straight rates and whether they're high or low. I mean, I realize that's always part of the conversation. It's also has to do with kind of the structure of how the funding is occurring. We called the ease of implementation of this a 6. Obviously, especially in the first part of this recommendation, cost will be a barrier to implementation, and it certainly would impact a large population.
Questions, comment on 2.3? Senator Kirshen. I'm sorry.
Thank you, Madam Chair. On that recommendation, about the 10 to 15%, what's the value of putting a range for reimbursement? Give us a number that works. You all these studies, 12%, 10, a range. That you don't know which one. I'm not sure how much money it is. I'd be more specific on that.
If I understand the reason for that, I think, and I understand where you're coming from, and normally that's what we do. And the members that were on that committee can probably speak better to this than I could, but I believe it was to say, if you can't give us a 15, 10 should be the floor. Rather than saying, okay, 15%, and then the next thing you know, they come down to 6, 5. That may or may not make much of a difference at all. That may have been the logic. Is there anyone from that committee? Perhaps you want to just bring that to our discuss. Tell us what was discussed in committee, Will, or one of our members here.
This is Will Warrens again. I think it's very fair feedback. That was, I feel like some of the issues that would need to be looked into by the working group are definitely pre-COVID, but have left the CMHCs in a fairly fragile system, or fragile funding even before COVID hit. And COVID, I think, might have added an element of maybe panic or crisis. And so that 10 to 15% came from the CMHC system. But I completely agree that, you know, if we were to proceed to another level of seriousness of increasing the rates, more specifics on that would definitely be fair to ask for.
Does that answer your question? Representative Lynn.
Thank you, Madam Chair. Perhaps I should have asked this while we were in a working group, but it comes to mind now. When we're talking about how we measure the impact, and we're looking at the frequency of the reimbursement rate updates, what kind of measurements are we using to determine how frequent it should be? Is it something that needs to be done yearly? Are we looking at 5, 10 years? I don't know the history of how often these are measured.
Do we have anyone that understands that in detail that can answer that? If not, we can come back with an answer.
This is Will Warrens again. I don't know if I have all the knowledge to answer that as sophisticated as it needs, but I will say that one of the reasons why we'd be calling for this working group is the lack of rate changes in Medicaid rates over a decade plus, and the lack of state grant funding in over a decade plus. So I still think it's a fair question. I think, however, if this working group would be addressing something that's probably been 10 to 20 years coming, and then I'm not sure, depending upon what decisions get made in that working group, how often it would have to be done, after that.
And this is Hina Shah from KHI. I can add to that. I think it was Keith Rickard's testimony that the special committee heard back in October. It was somehow back in 2007 that the last significant change happened. And I don't know if, Andy, you were going to say something similar to that. But the frequency would really give the legislature an idea of how often these reimbursement rates are updated or changed.
Yeah, I was just going to point out that this is Andy Brown with KDADS, and last year there was a proviso attached, I believe, to KDHE's budget to review the behavioral health rates under CanCare to other states and do a comparison. So I believe that there is work that's being done on that currently, and once that work's done, I think that can help inform the work group.
Further comments or questions? Right.
Madam Chair, this is Sarah Fertig with KDHE. Could I make a comment?
Yes, absolutely, Sarah.
Thank you. I just wanted to let everybody know I've asked staff to take a look at this recommendation to see what the dollar effect would be if we were to increase all behavioral health code rates by 10 to 15%. They're in process of doing that. There's a large number of codes, so they're working on trying to pull that and compare it against historical utilization so we could get a feel for what that would be. But they did send me yesterday what our top 6 behavioral health codes are in terms of utilization and claim count. So these are the top 6 codes in terms of the number of times we receive a claim under that code, and the top 6 codes in terms of the dollar volume going out. And in calendar year 2019, we spent about almost $185 million on those top 6 codes alone. So a roughly 10% increase in those 6 codes would be roughly 18.5 million. And a 15% increase just for those 6 codes would be approximately 27.7 million. So I don't have a complete pseudo fiscal note for you at this time, but I thought that information might be useful to this discussion.
Thank you, Sarah. I appreciate that. That kind of gives us how to look at things. Representative Bell.
One of the comments I would like to know, and I'm sure you looked at it, but the reason why, he explained the 10 to 15% increase, but when we looked at it, we highlighted that few changes to reimbursement rates had occurred in the last 20 years. And that is why we're in the shape we're in now, because we've made very few changes and we felt it was overdue. So I think if we keep that in mind, we looked at it in terms of ease of implementation and the cost of cost would perhaps be a barrier. But when we had a 20-year period of time in between and reimbursement rates, this made it very difficult. Thank you, Madam Chair.
Kyle Kessler.
Thank you, Madam Chair. This is Kyle Kessler with the Association of Community Mental Health Centers. And I suspect that Medicaid Director Fertig was referring was referring to an all funds amount, and that would be pretty consistent. I think that when we had done the fiscal note, and it wasn't just for codes that CMHC's billed, but for all fee-for-service, behavioral health, outpatient codes, it was around $1 million or a little less SGF share for each percent that you looked at raising. And that was really, again, to make up for, going at well over a decade without any significant rate increase at all. And it's one of the things, and not to tie a bunch of issues together, but some of the conversations that have occurred over telehealth, the differences between how commercial insurance looks at behavioral health rate reimbursement versus Medicaid is really night and day. The commercial and private insurance look at it annually or every couple of years, and we see better rates out of that, and more timely in terms of cost and salary and things like that. Medicaid is much, much different. And so we just haven't seen that kind of thing for well over a decade. So I just wanted to provide a little bit of that context. Thank you.
Thank you. Further comments, questions?
Madam Chair, this is Sarah Fertig again from KDHE. Thank you. I would just thank Kyle for clarifying that. We were referring to all funds on that, and I think his estimation is very correct.
So, Sarah, can you run that just real quick? Then the SGF portion would be what, about 40% of that number, approximately?
Yes, typically it's about 40% of that number for SGF.
Is it closer to 42 or to 40?
It's closer to, well, somewhere between 41 and 42, typically. Currently, it's less than that because we're enjoying a temporary 6.2% increased federal financial participation.
Right, but we don't want to bank on that one because we know what's going to happen.
Exactly. That's not a long term, but yeah. So typically, it's somewhere between 41 and 42%.
So if we wanted to work on a very conservative number of representatives, then we would probably get a 42% for that for SGF just to balance it out. Representative Carpenter.
So roughly $203 million.
On the 10% or 15%?
I'm just talking about the overall amount that she said, 465 million. Was it 85? Okay. So it's a little bit more than that. So 210 million SGF on the money we spend now for the 485 million. So we spend 210 million in SGF. And I think our entire Medicaid mental health fund is around 265 million for SGF.
Right. What she gave us was kind of a nice snapshot dealing with those top 6 codes. And that's where the 18.6, unless I wrote that down wrong at 27.7. So it would be 42% of either one of those numbers that would give us our estimate.
The increase.
Yeah, the increase, right.
About the percentage of the number that she gave us in SGF.
Right. That's the problem with us number of people. It's like we got to clarify which way we're looking at all funds, SGF, we're looking at right.
Madam Chair, this is Sarah Fertig again. If it would be helpful to the committee, I'd be happy to share that table that my staff provided with the top 6 codes and what our calendar year 2019 all funds expenses were.
I think we would appreciate that, and decide later on if it's something we want to add into our report as an amendment, just to kind of give a guesstimate of what that would be, but whether we don't, but we're not going to make that decision right at this moment. Further comments or questions? I'm glad you're on, Sarah. This is very helpful because Medicaid is complicated.
Well, and this is Will Warrens, and one last comment from me is just that I think another factor that's going on here that I would hope the working group could help make better is that we have, I view the MCOs as state employees. We work for the state, and right now we have, our providers, our CMHC system marching very appropriately to their marching orders, and we've got the MCOs due to some of these economic funding factors marching in pretty severe conflict to the CMHC system. And I think some of it has to do with some of these funding things that Keith Keith had talked about. So, and I don't think that conflict has to be there, at least not to the extent that it is right now. So that's another reason for me wanting to make sure that this is one of the recommendations that came out of the work group.
Okay, and Will, I may just not have understood what you just said there, and I'm trying to understand what that conflict that you're seeing, so I can understand that.
Well, as Keith was talking about, and I'm not saying this was explicit or whether this was just some erroneous takeaways, but right now, the decisions that were made back in 2000 and then 2007 have led providers to feel like to use select services and as often as possible to finance other services in the center. And then there's also some impressions that, you know, the overall funding of the CMHC system needs to be built upon the backs of Medicaid. And again, I'm not saying that was actually said. I'm just saying that that's the impression of some of the centers. And so when you have an MCO who doesn't understand that, trying to just look at the Medicaid population and what would be the right volume or intensity of services just for that member, not assuming that the finance from those services are covering other populations, it immediately brings us into straight conflict. You know, so any management or regulation of the services provided to the Medicaid population, if the MCO is unaware that it's also partially funding the uninsured, you know, then we've got, you know, all-out battle on our hands from these two entities. If we can find different structures that maybe doesn't rely on that quite to the same extent, I think we wouldn't have quite as much conflict there.
I don't like what you're saying, but I understand what you're saying.
Well, I'm saying it very calm, and I feel like a working group, you know, that can calmly proceed through some of these very delicate issues, I feel like would be a great way to address that.
I understand. Any further comments, questions? Okay, I believe you've got a 2.4.
Okay. Recommendation 2.4, this one had to do with focusing on suicide prevention. I feel like the entire committee definitely felt like this recommendation needed to be included. As we talk about some of the other nuances of mental health treatment, you know, we might be tempted to forget about the primary mandate we have to try to help prevent suicide, the life and death issue in the mental health arena. And so recommending allocating resources prioritized to areas of need, promoting local support groups and fundraising efforts, building capacity and increasing availability for survivors of suicide loss. A version of this recommendation was originally developed by the Prevention Subcommittee of the Governor's Behavioral Health Services Planning Council. We all know that the rate of suicide in Kansas is increasing. And I think we all have trepidation of whether there's another effect coming from COVID. Who knows whether that might affect those rates as well. I think we also wanted to emphasize specific populations, young, old, veterans, and make sure they are all addressed in this recommendation. This is another recommendation that I believe KDADS has already been putting some work towards. Sorry, I'm flipping from one document to another. We know that KDADS, let's see, KDADS has been working on a 5-year state suicide prevention plan. We know that KDADS has also had interest in creating and funding a full-time state suicide prevention coordinator. and that they've done a lot of work in a lot of different avenues on suicide prevention. And a lot of that, I think, was addressed in Andy Brown's presentation to the subcommittee on behalf of KDADS. So ease of implementation, we have an 8 here. I think the rationale for an 8 might be that we feel like there are some thoughts and plans that have been proposed, and maybe if those have long-term funding and are promoted, that maybe we can, so maybe some of the work has already been done, but it would require program change, legislative session, and agency budget development, and has certainly a potential for high impact, as you know, any efforts we can make to decrease suicide would have a huge impact for the state of Kansas.
Representing Landward here, yeah, the government has played a part. I can tell you that in my community of Wichita, our suicides are up 70%. 70% is a very scary number. Now, what that breaks down, I don't have the breakdown of the age groups on that, but that's what was reported for our city. One of the things I don't see in here, Will, and I think we discussed it in some of the committees, and maybe we didn't do it in all the committees because I wasn't able to attend all of the meetings all the time, is when we talk about, let's see, up in the rationale, that ongoing funding is needed to support and expand these efforts. So I think when we talk about, you know, whether it's creating a new program or it's expanding, there was a lot of discussion around making sure that we have, and I believe Tina can tell us what the wording was in different work groups, that we have to have measurable, trackable data. Are you having trouble hearing me, Will?
Well, either that or I'm getting old, one of the two.
I'll try to talk louder. Usually people don't have problems hearing me. So, but it's going to be important, staff and KHI, that in one of these recommendations that are looking for expanding or adding funding to programs or creating a new program, that we talk about data that has measurable, traceable, trackable, whatever the term was we finally settled on, to monitor these programs. If we can't measure it, it's not worth us funding them. And we have found out how important that is in the mental health pilot. I know everyone's getting tired of talking about that, but there's been a lot of research done into that, to where we can tell you what happens to every single one of those children. And if they're meeting each one of the tracking mechanisms that we have. And if they're not, then the school district and the school building, I should say, and the CMHC staff can jump on that and target and zero in on what's happening with that child. And I think anything in mental health is important for us to be able to measure. It's something I think as a state, you know, having been around here long enough with budgets and everything, is that we don't trace that. We don't track our data. We just say, hey, this is a great idea. It feels good. It's warm and fuzzy, and let's just do it. But we don't know if it's really successful. It may appear successful, but it doesn't mean that it is. And I think that we're seeing our agencies, you know, trying to make a trend towards that. So it's not like I'm talking about something new, but that. So we need to make sure, whether it's staff or it's KHI that works on this, that we, in each one of these sections, hopefully for tomorrow, that we clarify the language that we came up to do that. Representative Ballard.
Madam Chair, I'm looking at Barbara Ballard, representative. In this last part of the sentence, I thought we did highlight it. I don't know if it's enough, but it says working group members and members of special committee repeatedly highlighted the importance of data to drive ongoing decisions, repeatedly to policy and prevention. Was that not enough? Because we did make the point of saying that we had to look at the outcome. We talked about accountability and everything else.
And I believe it, Representative Landwehr here, and I believe it was on a working group that I was on with Representative Carpenter, and we worked with KHI on language to identify, to break that down a little further, because we can say data, but what does data mean? Data to you is different than data to me. And if we don't have measurable and trackable, then it's not good data, because we know by experience, and you and I've done this enough years, we collect a lot of data, but we don't necessarily have it in a reportable format. Representative Ballard.
Thank you, Representative Ballard. And when we looked at this, remember the language we were working on, we kept trying to decide which of those the word would look better. I don't know, was it acceptable? Remember we were developing language. I don't know which one it is, but remember we crossed out one word. Because at one point we talked about sophisticated, and we changed that language. And then we did additional language across, but we said it wasn't accountability, but I don't remember exactly what it was. But I agree with you wholeheartedly, and I think this was an effort, but there's someplace else there that we did indicate that everything should be based on, do we have the research, do we have the data, what's the outcomes are.
Right, so I think what we'll do is, I know the Bishop has got a question, but I think before I come back to you, Representative, is I'm going to go to Hina or Carly, because I believe it was Carly I was on that working with. I don't remember if that was the Friday or the Monday.
Yeah, this is Carly Houchin at KHI. By my recollection, excuse me, the discussion, and then we've added this throughout several of the vision statements and the report overview portion. The language that we used was or arrived at was measurable outcomes to drive decisions. So that was the kind of the general statement that we've attempted to use throughout those vision statements to recognize the ongoing importance of collecting meaningful data to inform how the success of these recommendations are understood. So that is kind of piece one. And then, as Hina briefly highlighted before, throughout the body of the report in each of those tables, the measuring impact measures attempt to describe some of the things that exist currently that we see or that we understand in partnership with the state agency to be key measures to understand the issue described in that recommendation.
Okay, I think Carly, what we're going to need, and I apologize for adding this at the late hour, but this will be for tomorrow, is that we add that the first words you provided us on that measurable piece probably need to be in these, like the 2 well, any of these versions that talk about funding, expanding, or increasing, making new programs in these recommendations, because some people, they may just go to that chart. They may not go deep into the body. Have I lost you? I do that easily with people.
No, this is Carly at KHI. What I'm understanding is that you want the language on measurable outcomes to drive decisions referenced throughout each of the recommendation specific tables. So make sure that anytime we're talking about a funding decision, people know that the intent is that the piece about measurable outcomes accompany that. Am I reflecting that back correctly?
Yes, ma'am.
Great.
I'm just trying to think of how, as a legislator, if I wasn't as intimately involved in this process and I grab this report, what am I going to look at? I'm going to grab this recommendation piece first. Then if I get into a specific recommendation, then I'm going to go deep into the body a little bit further. And I just want people to understand that intent, because I think it's something that, we've started over the years in various programs, and now we just need to, emphasize it on a continuous basis. And I'm going to recommend Carpenter is in agreement with me, unless he shakes his head otherwise, that if we can't measure it, we can't manage it. So, and we're not going to finalize all the wording and everything until tomorrow, but that's why we're making tweaks today as we go through. So I appreciate that. Representative Bishop.
Thank you, Madam Chairman. This is Representative Elizabeth Bishop, and I just want to point out that we are, in not too long a time, going to be presented with both the challenge and opportunity of the 988 crisis line coming into effect, which, if I'm not mistaken, is supposed to be July of 2022. And that may seem a ways away, but it's going to be a considerable undertaking to build on the crisis line networks that exist now and to deal with what is quite possibly to be an increase in business as a result. And I wanted to mention that it's sort of subsumed in the statement. So I'm not suggesting we change any wording. I just wanted to kind of stick a pin in that.
Anyone else on comments, questions? Representative Lynn.
Thank you, Madam Chair. This is Representative Lynn. I just wanted to make sure that we are able to support the organizations, the local organizations that maybe not are asking, maybe they're not asking for the government's assistance, but that we can come alongside them and acknowledge that they're there so that they can make sure that we are making sure the general population knows that those are in existence. For example, like the Zero Reasons Why group, maybe they're not asking for assistance, but we want to make sure that we can come alongside them so that we can direct resources, maybe not funding to them, however they see fit.
Okay. Other comments, Representative Arnberger.
Thank you, Madam Chair. Real quick, I just want to make sure I have this completely understood. I know that I think it's KDADS, that they wanted to add the suicide prevention. I don't know if the position is actually called the suicide prevention head person. Even though, and I know that we talked about it because since the AG department has a 0.5 FTE position, that when I mentioned it a couple times ago that they wanted all of it underneath one agency instead of having two different ones. I'm just curious, maybe this might be for Andy Brown. Was it 3 FTEs that you were wanting to hire, and could you kind of brief our memory on that?
So this is Andy Brown with KDADS, and I think our primary request at this time as a recommendation would be that we work to designate a single state agency as being sort of the lead agency for all the agencies that are involved in suicide prevention work. Right now, by my nearest count, I think we have as many as 6 or 7 different state agencies that have suicide prevention programs. And we are doing our best to try to coordinate that. However, we don't have a statutory designated lead agency. And then as part of that, I feel like it would be important to have a full-time position within the state that's designated as a state suicide prevention coordinator. And as indicated, we do have a youth suicide prevention coordinator position within the AG's office that's a half-time position. So a full-time position at whatever lead agency is designated, I think would be appropriate.
So just to follow up, this is Representative Arnberger again. Just to follow up, do you feel that it would be more beneficial to have just one agency in charge of all of it, or do you feel as if maybe we should, or are there checks and balances of having it spread out, or on the flip side, are we all doing the exact same work and not getting the bang for our buck by doing it that way? If that makes sense, what I'm asking.
Yeah, I believe so. So as I'm interpreting your question, you're asking whether or not it makes sense to try to put all suicide prevention as the sole responsibility of one state agency. And I don't think that's the appropriate course of action. But I do think it's important that we have a designated lead agency that can correspond and kind of hold the work of all the other agencies jointly, so that it's coordinated and we're not stepping on each other's toes, and we know what our federal funding opportunities are and how we're pursuing those, so there isn't any confusion between the different groups. And then also that will help us consolidate and really maximize how we utilize the resources that we do have available from the federal government for this purpose, and hopefully really better coordinate our suicide prevention efforts so that we can have a better impact here in the state. As everybody knows, those numbers are going up, not down, and that's the wrong direction for them to be moving.
And I might add to that comment a sidebar that I just had with Representative Carpenter and Representative Ballard, who both serve on the Social Services Budget Committee, is to make sure they take a look at that and, get that also, it funnels into one place, so you don't have to look across 6 or 7 agencies, so that definitely makes sense. It's not something we'll add into this report, but definitely something that needs to be addressed. Further comments or questions on the 2.4? All right, seeing none, ready for 2.5, Will.
Okay, so recommendation 2.5, this one I think definitely, maybe they all do, but this one definitely goes into the category of where other members of the work group have a little bit more knowledge than I do. But it was recommended that the state continue to increase the proportion of the money in the problem gambling and other addictions grant fund that is applied to treatment over the next several years. This was a recommendation originally developed by the Committee on Alcohol and Other Drug Abuse of the Governor's Behavioral Health Services Planning Council. Currently, 2% of the lottery gaming facility revenues are to be allocated to support addiction services. And I don't understand all the details of this, but my understanding is that in the conversation the working group had is that the definition of how those funds can be used might be a little bit too broad, perhaps, in the fact that it's drawn some of those funds away from addiction services. And so the recommendation would be to maybe get back to the purpose of those funds and have them allocated more tightly for addiction services. And again, if I'm other working group members, please step in if I'm misstating that, but that's my understanding of this recommendation. The ease of implementation was considered a 5, would require legislative session and potential for high impact 5. And that's what I have on that recommendation.
Representative Lambert here. Comments, questions?
Representative where I'd like to make a comment. It's Deb Stidham.
Just a moment. I've got Senator Alley up first.
Thank you, Madam Chair. This is Larry Alley, Senator from Winfield. My question is that 2% of the was set aside for the problem gambling. Are we spending all of that 2% on problem gambling?
This is Will Warrens. I don't know if, Charlie Bartlett may happen to be on the line. My understanding is no, but I say that with caution, with inviting others to step in.
Well, my issue, I think, was the funding was identified as a problem gambling fund, and taking the money for other conditions, if you want to call it that, and using it for something else does not solve the problem of problem gambling, which the fund was set up for in the first place.
Representative Valley, I think if you were to look at that budget, you would find that that money has been spent in other places for many, many years. And I think that the comment in here is to try to get it back to the gambling addiction. And many times along with the gambling addiction, you find substance abuse issues and they'll help that go along with that. But the money has not been specifically spent on, I don't know that it's even been fully spent on the gambling issue since it was actually put into place when the state-owned and operated casinos became law.
Can I comment? Pardon me. This is Larry Alley again. The issue here, is it the definition of addiction that is in that bill that needs to be changed, or should be just be for the problem gambling?
Well, that's a representative member here. That's a decision that the legislature would have to make, Senator. And the only thing I was clarifying was when that was set up, when the state-owned and operated casinos came into play, that ever since then, if you go into the details of the budget, you will find that that money has not been solely used for gambling addiction. So if clarification needs to be done, Of course, keeping in mind the legislature can always override any statute that we have out there on the books. It's something that we can take and look at. In this report here, we're not changing the definition, but that is something that the legislature could, if they choose to change that. I don't know off the top of my head what that definition is, but I believe it just says gambling.
Representative, this is Deb Stidham. I can offer a little context. I was actually working in state government when that law was passed. If I may.
Go ahead, Deb.
So the name of the fund is actually the Problem Gambling and Other Addictions Fund. And 2% as written into law was considered to be quite a hefty amount, kind of unprecedented actually at the time, for a fund to be set up for problem gambling prevention and treatment. And so most of the time you might see 1% or 0.5%. And as you might imagine, the legislature as a whole was not very enthusiastic about passing a legalized gaming bill. But there were people who understood that the substance use disorder treatment system was underfunded. And so as a result, they made it 2%. Because as you just spoke to, the co-occurring nature between problem gambling and mental illness and substance use disorders is certainly very prevalent. So they understood that primarily, and at the time, and it's true across the nation, that it has been the alcohol and drug field that has been the most eager to embrace treating this population. Those are your folks seeking these certifications. And I'm not saying exclusively, I'm just saying that tends to be the field who has gone after treating this population. And so it just made a lot of sense to shore up the deficits in the alcohol and drug field with this 2% of net revenues. So the definition as it stands allow for this, and it allows for the things that we're talking about. What we certainly have to be careful about is not kind of robbing from Peter to pay Paul. We want to be sure that the problem gambling prevention and treatment fund portion is also adequately funded. It is certainly my observation that it's really not ever been. It's never really been a priority despite the revenues that have been attached for problem gambling to mitigate the harms that we know come from legalized gaming. So that portion of it absolutely, I believe, needs to be taken a look at as well. There was language introduced in the sports betting bill last session to actually correct what has been seen as some of the deficits in how that definition of what the funds can be used for was crafted. And so I believe that sports betting bill, of course, did not go anywhere because of COVID. Anticipate it certainly coming back up again. I believe that the new language for that direction of the funds, because of course, if we're going to legalize sports betting, we think that there should be some monies for prevention and treatment of problem gambling for that as well. And so that could actually be an increase in that fund, and also correct those, broad language that was unintended to begin with. Unfortunately, the recession hit right when the casinos started coming online. So it was an easy target to shore up for other things that were deemed more important. So I, for one, am very pleased that this conversation is happening and look forward to more.
Thank you, Deborah. Please, Valerie.
And thank you, Dr. Ballard. I am pleased and I agree with your comments, especially when the recession hit, because then it was like we were looking for places for money. I'll use an example of one sitting in this very room that we had a very heated discussion. 650,000 was proposed for domestic violence. And no one could dispute the fact that domestic violence was an important issue here. And then it came into yes, for people that were drinking too much. And what was the source? Well, we were supposed to be putting billboards up, giving to organizations in town that would talk with problem gamers, giving to counselors or whatever. But that fund, because of other additions, has been an area when we didn't have any money, we had 2%, and that money was sitting. I mean, it was just in that fund, and it was a go-to, and take what you want when you want it, or how much you want it out of it. And as much as many of us argued that that was not use of the money, if we were doing everything we were supposed to be doing, of trying to prevent it or educate people about it or address the county, it would have been okay. But in this case, we really were not, and we just used the money for what it is. And yet you can't do that. Or some of those other areas were important. But no, that money that has never been just for property.
Other comments, questions, Representative Lynn?
Thank you, Madam Chair. This is Representative Lynn. I was looking up, I found a problem gambling and other addictions fund strategic plan, which was from fiscal years 2014 to 2017. And in it, it lists the goals that they had for how this money would be spent. And they said no less than 1/3 of the available funds would be dedicated to programs and services directed at reducing gambling related harm in Kansas. The second goal was approximately 1/3 would be utilized to address urgent needs in the AAPS administered alcohol and drug treatment system. And then the remaining would be directed at addiction system supports designed to improve the efficiency and effectiveness of problem gambling and other addiction services. And then any other new revenue would be applied to addiction services needed to fill critical service gaps. So that's what I found.
Thank you. Any other comments or questions on 2.5? Seeing none, do you have anything else that you would like to add, Will?
I think we just had, I don't know if this is the time to talk about it, but I think we had one more in this section. I think, is this where we talk about, there was one more topic that was in a strange category all of its own, and that is a high priority discussion item, Medicaid expansion. And Medicaid expansion has been recommended by multiple task forces, mental health task force, governor's substance use disorders task force, and the child welfare system task force. I think the reason why you don't see it in the same format as the other recommendations is because as the working group was talking about this subject, there were very eloquent and intelligent people on both sides who had feelings regarding Medicaid expansion. And I don't think the working group felt comfortable, weighing in pro or con on Medicaid expansion, because it would be trampling on very intelligent positions on the other side. So I don't want to say we punted on it. I think it's more that, to be respectful of everyone's point of view, we just designated it as a something that we would recommend the committee discuss with high priority, because my understanding is whether you're for it or against it, no one would argue that. I think its ease of implementation score would be extremely low, but its potential for high impact, I guess you could say good or bad, would be extremely high, depending upon your point of view. So that's what I have to say on that subject.
Any comments, questions in regards to the discussion item?
Madam Chairman, this is Elizabeth Bishop.
Representative Bishop.
Yes, Representative Elizabeth Bishop speaking. And I would just like to weigh in. I know that our process is based on consensus building, but I wanted to simply weigh in with the fact that I would be in favor of having the issue of Medicaid expansion appear in the document that we're preparing in some reasonable fashion. I realize that consensus on that is difficult, but it is a a very important and live issue and has a tremendous impact on healthcare in general and mental health care in particular. And if there was any way that we could include it reasonably, I would be all in favor of that.
Senator Petty.
I have to concur with, this is Senator Pat Petty, I have to concur with Representative Bishop. We can't ignore the fact that we have lost over $4 billion and continue to lose that much money, or continue to see that fund grow every single year. We're talking about anything when it comes to healthcare and improvement, in this case for mental health. We have to be honest about the potential aspects of funding sources. And we already have, I think, earlier in our discussion, when we asked for some more input and for areas that had impacted, I mentioned Medicaid expansion. So I agree. I don't see how we can put out the support for that.
Representative Ballard.
Thank you, Madam Chair. I was waiting to see what other people have something to say, because actually you heard Dr. Warren's talk about the discussion we had on Medicaid expansion. Actually, one of the main reasons I think this is on here is because we really had a very lively discussion about it. And one that I felt, talk about mental health or any other kind of illness and not have a discussion about Medicaid expansion. And that's why it's here, that we're recommending that we have this discussion, and whether we decide we're going to do it or not, but to leave it out when we know that's the big issue that's really out there. And I pointed out that the House has passed it several times. The Senate just didn't pass it. And so we can look at it. So at this point, I'll probably hear from the senator. But you know, when we talk about it, because that was part of our discussion that was really going on in our committee. But to be respectful, it was, we're not going to force an issue that we don't have to force, that we don't know if we have the votes or not. We're not going to force the issue, but it is a high priority, and we really should in this committee discuss it. So that's why this recommendation is there. Thank you, Madam Chair.
Representative Carpenter.
Thank you, Madam Chair. I did miss this meeting when this discussion. I'm very disappointed that I missed that meeting, because obviously many of you know where I stand on Medicaid expansion. Quite frankly, I understand the discussion, but I don't want this to take away from the other important things that we have a possibility of working on and accomplishing. So we can discuss Medicaid expansion all day long. The likelihood of passing the legislature, at least in the next 2 years, is slim to none. And so I just assume it's concentrating on things that we actually know that we can get done. So that's my take on that. I wouldn't mind having this deleted completely out of this section. I was shocked when this. Thank you.
Further comments, questions, discussion? Representative Arnberger.
Thank you, Madam Chair. I just would like to concur with Representative Carpenter, and I agree with everything he said.
Senator Allen.
Thank you, Madam Chair. If I remember the discussion that we had last time, it was a recommendation that we put Medicaid expansion in as a recommendation. And I think we moved that away from a recommendation because, number one, we didn't have consensus, but also two, because we don't want to take away the good work that this committee is doing on mental health, to have a discussion on Medicaid expansion that may or may not be the center point of this work that we're doing here today. And there was good work done last session or the session before, when we passed the Farm Bureau plan, and I believe that we need to continue that type of activity. But putting it as a recommendation would not, would take away from what we're doing here. So thank you very much.
Senator Petty.
Well, mean, this is a report, it is gonna go to the legislature, and, you know, each working group had priorities, and I respect that, that this working group, you know, due to as this has always been a very political issue, but if we're talking about finances and we're talking about what resources that, you know that we are always going to be looking not only to the state, but to the federal resources as well. When we talk about, as mentioned here about, you know, changes in codes and from the federal level. So there is no recommendation that I see on Medicaid expansion, but I do believe that it would be neglectful to not have Medicaid expansion mentioned within a report that's dealing with mental health modernization and reform. I just see it that we really are making this a totally political report if we don't at least have it that it was discussed within those committees.
Senator Kirschen.
Thank you, Madam Chair. Senator Kirschen from Button. And I want to just, I'm not afraid to have a conversation in this meeting and discussion. The reality is it didn't pass the Senate. For whatever reason, it didn't pass, and the votes weren't there. And I think what the Carpenter and others have said is, I don't mind it being mentioned in there as other things discussed, but not as a recommendation, because that could hurt it. I don't see this getting passed anytime soon this year.
Representative Ballard, excuse me, I'm sorry, Senator.
We're still going to talk about Medicaid expansion, but who knows what that might happen.
Representative Ballard.
Thank you, Madam Chair, Representative Ballard. And you know, that was the issue that we had in our committee, exactly that conversation. And that's why it wasn't mentioned as a recommendation, because we could not agree on that. But what we did agree, and that's why I said you would hear from the senator, because Senator Alley and I had this discussion, and it was very respectful about how we talked about it and everything else. And it was a compromise, but no, we weren't going to push something when we had other things that we really have to deal with on mental health, but that it was an important issue that we should have that discussion. I would be very disappointed if we totally eliminated as if Medicaid expansion did not exist, when I thought I was being very gracious, understanding both sides of what it was, and that we should have that discussion. And our working group was really a cool group. I mean, we didn't get into it all over. We just talked about what it was. This is not going anywhere, so let's back off and let's move on. And I thought that was very respectful. We were working with each other, we talked to each other, we listened to each other, and we heard each other. So just to eliminate it as if it didn't exist, that's not what our working group did. That's why it was just here as let's have the discussion. Thank you, Madam Chair.
Representative Bishop.
Thank you, Madam Chair. This is Representative Elizabeth Bishop, and I would like to see us give the proposal in the latest draft a number. I think it would be 2.6, and that we include it. It does not have, it's written in general terms. I think it states the situation very well. And to exclude it would, I believe, undercut the credibility of the report.
Further comments or questions?
Yeah, this is Will Warrens, and I guess, you know, this might be naive, but, you know, if we did include it in the report, you know, perhaps there could be equal language to both points of view, you know, that has been somewhat vetted and is felt to be important to both sides, you know, and then it could be included.
Any further questions or comments?
All right, Representative Landwehr here, and I think that Representative Ballard expressed my position on this very clearly. And this was indeed collaborative compromise to include it, but not make it a recommendation. To give it a recommendation number elevates it to a level that I think creates an issue. I'm not afraid to have the discussion. I will continue having the discussion. And I'm sure we will have the discussion during the session. But it's not going to be a highly recommended item. And part of that has to do with, if you look at the full picture of mental health and some of the recommendations that we've made that are going to require funding, then where is your priority? Is your priority within this report going to be on mental health? And maybe it's the increase in reimbursement rates. That's just one example. The regional hospitals, the PRTS, I always mess that acronym up, the CCBHCs. A lot of funding items are out there, and to come in with one item that can just suck up the whole budget became problematic. So the consensus, and Representative Ballard and I have spent many, many years together on social services budget, doing everything by consensus, which means that when she and I would walk away from a budget at night, both of us were probably happy or unhappy, but it was a true compromise, and that's what compromise is about. And so this language and in this position, the way it's presented in this budget, then was a consensus compromise. We know that the issues out there, we know it's going to be discussed, but it's not something that the working group felt like we should destroy the rest of the report and have one focus on one program, which could easily be done if we elevate this to another level in this budget. There's a lot of good programs in here that are going to need our financial assistance. And there's none of us legislators sitting in this room that don't understand that's going to be a struggle. I know that
Chair.
Representative Bishop, please.
Yes, thank you, Madam Chairman. I understand what you're saying, and I would like clarification as to whether that language or that paragraph between 2.5 and the end of this section will be included in the final report.
Maybe you should let me finish, Representative Bishop, and I think you'll hear what I've got to say here in just a moment. We're hearing, we're looking at the revenue numbers, and they're a lot better than what we had anticipated. But things that people don't realize is that those numbers can be looking high, they can be showing us in the black, but when you start coming in to fund things that are statutory, such as our consensus caseloads numbers, that can eat up budgets pretty fast. So I would hope that the committee, without us going into a division vote, would accept this report with the language as it is written in here to be that compromise between both sides. And I know there's individuals in this room that feel very strongly on both sides. I happen to be one of those individuals. So my recommendation is that we keep the language as it's written. We don't elevate it to another position within this report. Does that satisfy you, Representative Bishop?
Yes. If it appears in there, I think it's accurate. And I believe that the process of achieving consensus would be lengthy, and we've got 2 days worth of work. I do think that if it appears in the report, it will assist in, as it is, incomplete as it is, but at least will assist with the credibility of the report that we looked at it, we discussed it, and there we had folks on both sides that weighed in. Thank you, Madam Chair.
Representative Lamb, we're back, and the idea of this report is not for us to come in with, each of, if the idea of this report was just to allow, one individual to take and design it, I could have done this by myself. But it wasn't. We needed everybody at the table, and we needed differing opinions and differing views. We needed the experts that we had all around the state to bring into this. There was a reason that the working groups were not assigned chairs and vice chairs of legislators. And it was to make sure that we had a fair, open report coming back and bringing all the reports that we've done in the past together in this. So we don't want to get it bogged down on any one issue. Any further discussion, questions, or comments? Okay, I think that's it for you, Will.
Thank you, Madam Chair.
Thank you.
Madam Chair, this is Hina Shah. We have Greg Hennon next to discuss community engagement, starting with the vision and then discussing the recommendations.
Okay, and I just wanted to let folks know that I'm not necessarily paying attention to things coming in on my phone, as I've got staff texting me to let me know when we've got speakers online that want to speak, or also the issue that our lunch has arrived when we're ready to break, and those types of things. So don't think that it's a distraction, but pay attention to other things. It's staff keeping me informed. They're kind of I wish I had a little mic in my ear that could just talk to me, kind of like the Secret Service agents. That would be pretty cool. All right, now we're ready for the policy. Yeah, the policy and treatment, right? No, community engagement. I'm sorry.
Yep, last topic for this working group, community engagement, starting on page 17. Thanks, Greg.
Thank you. Greg Hennon with 4 County Mental Health Center. And as already been mentioned, this was the last section that our subcommittee worked on, looking at community engagement and making sure resources are available and effective close to home. On page 18, you'll see recommendation 3.1. It's in relation to crisis intervention centers. And that recommendation speaks to the importance of utilizing state funds to support the expansion of crisis intervention centers. And we talked earlier about the development of crisis stabilization units, and that those will eventually be licensed as crisis intervention centers as they meet regulatory standards. Right now, the crisis intervention centers that are being developed are funded with the lottery ticket vending machine dollars that are coming in. And I know the lottery machines got a slow start, but the dollars that are there are in support of the centers that exist, but in no way is adequate to place a crisis intervention center regionally in all of the areas of the state that could utilize that. These would serve as a relief valve to the state hospital by treating people locally or close to home. It can reduce wait times in the emergency rooms, decrease the need for that psychiatric admission in an inpatient unit, oftentimes quite a distance away from their home, and would stabilize the crisis services that exist across several communities. The challenge, of course, is the cost. But making that a priority, it would be easy to implement and have a significant impact both on the individual lives of those receiving that service, but also on the community partners, because community mental health centers, hospitals and ERs, law enforcement, etc., all end up very heavily involved, and Department of Corrections or county jails all end up pretty significantly impact with that crisis work that needs to be done. So that recommendation again is to expand funding for crisis intervention center development, and I'll stop there in case there's comments or questions.
Comments or questions on 3.1? All right, seeing none, let's proceed forward.
Okay, then on page 19, you'll see a recommendation 3.2. It's in relation to IPS community engagement. The individual placement and support program is probably better well known as a supported employment program. And the recommendation here is to increase engagement of stakeholders, consumers, and families and employers by requiring agencies implementing the IPS program to create opportunities for assertive outreach and engagement for consumers and families. Really what that means, well, a couple of things. It's a recognition that employment is an important social determinant of health, and that these supported employment programs have a significant impact in overall recovery. But there would be some program overhaul necessary for this recommendation to be followed through. Right now, activities that help support this program, such as job development, going out and doing that liaison work with employers to see if they'd be willing to be employment sites, and some of that job development, and again, outreach with supportive family members, those aren't reimbursed services. At least that's my understanding, that those aren't reimbursed services. So that ends up being a lot of activity that is required of the IPS programs that is unsupported, yet is a very necessary piece for success. So this recommendation seeks to close that gap and make it an important recommendation, or important requirement, I should say, to create those opportunities for assertive outreach, but that the program also support that activity. Again, I'll stop there for questions.
Questions, comments on 3.2? You're doing an excellent job. They all fully understand it. Thank you very much.
Absolutely. Those two recommendations were our subcommittee's immediate action community engagement recommendations. We have two more that are recognized as strategically important. So over a longer period of time, recommendation 3.3 in relation to foster homes, this is on page 20, recommends that the state of Kansas invest in foster home recruitment and retention by increasing funding for supplemental training on behavioral health needs, and providing additional financial incentive to support serious emotional disturbed youth. What's kind of at play here is you look at foster homes and the training that the foster families get, which is very good. It's necessary, but in many ways it's not sufficient. And the belief is that by increasing funding for behavioral health training and needs by the foster homes themselves, that there would be fewer disruptions in those placements, and that families would feel a little better equipped or armed to deal with some of the challenging behaviors that they have displayed. And also, and I'll have some other committee members speak to this, the financial incentives to support the SED youth. There are some SED waiver services, one called a professional family or resource family, and it is a family that has gone through some additional training and has got some skills to deal with the significantly behaviorally challenged. But those foster homes, professional resource families, are just far and few between in the state of Kansas. And yet that is an important service for that youth. So I believe that was a part of the conversation and recommendation that there be further investment over the long haul for behavioral health training of foster families. I'll pause there.
Any comments, questions on 3.3? I guess the only comment I would have is that, this is definitely, when Greg talked about this being far in between, it's one of the many problems and one of the many reasons we see a lot of movement from home to home to home on children. This is one of many. And we don't necessarily properly train our foster parents for some of our higher needs foster kids. Okay, Greg, it looks like we are ready for 3.4.
Okay, on page 21, you'll find recommendation 3.4, again, as strategic importance. This speaks to funding for community liaison positions specific for justice-involved adults and youth that have substance use disorder or co-occurring conditions. The hope here is that that liaison could help with transition as people are in a pre-release situation, whether that is in the county jail, but I suppose even in the youth settings, if they're in a detention facility, to make sure that they have proper kind of case planning or care coordination to be tied back to the community that they're going to be returning to, and they have a productive or adaptive plan to not only be supported, but to engage in the treatment modalities that best serve them. It would require some programming change, and funding is certainly a risk for being a barrier, although it's noted that SAMHSA may have block grant dollars available to support that activity. So it's a moderate ease of implementation, but has a reasonably high impact score of 7 out of 10, and really looking at reducing recidivism and keeping people out of detention facilities and working more adaptively and productively as citizens. That's the end of my report.
Comments, questions, committee on 3.4. Seeing none, looks like you've completed your work here today. Am I correct? Oh, wait, Representative Ballard has something.
This will be very brief. I want to thank both of our leaders for doing an exceptional job. I mean, when we had to vote on who we wanted to, and they stepped up. So to both of you, Greg, and to Dr. Warrens, thank you so very much for doing an outstanding job.
Absolutely. Thank you.
This is Will Warrens. Thanks, Representative Ballard. And I could turn it right around and say the state representatives and the state senators, as well as all the other work group members. I mean, we really got along great, and our conversations were very productive. And I'm impressed by all the input everyone had, and it made it very easy, you know, to be in the role I was. So thank you.
I agree.
It's kind of nice to see how we operate a lot more together than the press makes it out to be. You think that all we do as ours and D's is that we argue, bicker, and fight, and never agree. We actually agree a whole lot more than we do the other. It's that very small percentage that makes the press. So, okay, so committee, I think that we'll break on the going to prevention and education. Is that all right with everyone? Break a few minutes early, and we're going to go ahead and grab our lunches, and when everybody's on Zoom, feel free to also do that themselves. And we will reconvene back here at 12:15. That's right. I know he's coming. Oh, yeah, I know. Right. No, but he's oh, no worries. Yeah. Yeah. I was having
make sure
Oh, I got it.
I'm on the right page.
School, you know, yeah. Yeah. And you will, it's just a matter of, yeah.
No, you're very excited.
Takes a minute to heat up. All right, we're going to go ahead and continue our discussion. And I believe that we are on page 23, 4.1 recommendation. Is that correct?
You are correct, Madam Chair. This is Hina Shah at KHI. And I'm going to.
All right, this is Don Jordan. Can I make one comment before we start?
Don, you are always welcome to make a comment. Just don't disagree with the chair.
Well, I know better than that. Now, I just wanted to take a moment to thank KHI and particularly call out Carly Houchin. She did a really great job of getting everything organized, of running the meetings and making us effective. And I just want to thank her and call her out for doing such an excellent job that I think we just presented a good presentation. And a lot of that goes to what she did to put us in the ability to do that. And so thank you very much, Carly.
I think that all of us, the process would echo those sentiments. Thank you, Don.
Certainly would. Thank you, Madam Chair.
This is Carly Houchin at KHI. Just want to maybe jump in quickly to say thank you, and also just to highlight that it's certainly been a team effort over at KHI. Hina, Carrie, Peter, Sydney, our whole communications team getting this report together pretty quickly. It's definitely been a team effort, and we all appreciate the comments. Thank you.
So who's presenting, Hina?
All right, so I will invite Deb Stidham to present on prevention and education, if she can walk us through the vision and also the recommendations. Thanks, Deb.
Good afternoon, Deb Stidham, representing Kansas Association of Addiction Professionals on this committee. So our committee looked at 3 topics: prevention, education, treatment, recovery, and special populations. So the vision for prevention education was that modernized prevention efforts will seek to meet the behavioral health needs of populations at increased risk for poor outcomes, requiring a collaborative trauma-informed approach and appropriate funding. So on page 23, 4.1, for immediate action is 988 Suicide Prevention Lifeline funding. So as Representative Bishop talked about this earlier, this is a national effort that's getting ready to come on board in 2022. And so the recommendation that our committee is making is that we should collect fees via phone bills to support this initiative. And those fees would assist us to increase the percentage of Kansans in crisis being connected to in-state crisis services. And so currently that's at 60%. We would like that to be a much higher number. As you might recall, the National Suicide Prevention Lifeline phone number is going from a 10-digit phone number to 988. So we think that that will increase awareness and access and ease of people to know who to call. And we certainly want our system to be ready to meet that increased demand. And I'll take any questions.
Any comments, questions on 4.1? All right, seeing none, let's proceed. Or did you have something? Go ahead. 4.2 now.
Okay, great. So the next recommendation on page 24, early intervention, also consider for immediate action, is to increase access to early childhood mental health services by including, basically to add additional codes. So we would just need an amendment to the Medicaid state plan to explicitly add codes for early childhood screening, assessment, and treatment. This was already recommended by the Mental Health Task Force, And as we all know, the sooner you intervene with problems, whether they're health related, behavioral health related, the more likely you're going to have positive outcomes. And so this would not only benefit some of the populations that we talk about quite frequently around foster care, low income, and those with limited English, but it would also benefit potentially a very large population and produce some cost savings that we would see from dealing with these folks, with these youth at a much earlier age rather than waiting until their problems are serious.
Representative Lambert here, maybe I just misunderstood and I'm not finding here. Did you mention something about opening codes?
It would require additional language in the Medicaid state plan.
Is that mentioned here on the report and I'm just not seeing that?
It's actually the first sentence, including additional language in the Medicaid state plan to explicitly cover early childhood. I think someone else can speak more.
This is Gary from KDADS, and yeah, we would need to have some additional diagnosis codes approved to be able to treat the children that are under age 5. Currently, kids under age 5, we don't have the appropriate diagnosis codes always to be able to provide the services that are needed, and it makes it very difficult to make that happen. And as Deb was saying, if we could intervene with children and families before that age of 5, would create a significant savings, we believe, in the services that are needed for kids at age 5. So it's the question here would be having some additional diagnosis codes to be able to serve the children under age 5.
If I understand you correctly, it would be additional language needed in the Medicaid state plan, plus the possibility of additional codes being opened, correct?
Correct.
Okay, because I'm thinking that, to make sure that we're transparent on everything we're doing and that we understand that there is, anytime you open up a code, for those of you who are not familiar, there is a cost associated to that. You have to always be aware of the codes and what codes, what the fiscal notes that would be on it. So I think to add in here somewhere, staff, including additional language in the Medicaid state plan, and possibly open codes. I'm open to suggestions on this where you feel is the best approach.
Chairwoman Landwehr, this is Sandra Berg with United.
Yes, Sandra.
One thing I wanted to add, there is a diagnostic manual just for early childhood that the state of Kansas currently doesn't use. So that might be another option to look at the early childhood.
And I think that's basically what the group was talking about, that we do have those codes. The codes exist. We just currently don't use them in Kansas.
Well, we don't, sorry, Gary, this is Sandra. We don't use them for diagnostic. We don't have a diagnostic system for using the codes within.
Thank you, Sandra. That's exactly what I meant.
Okay.
So now that we've made this as clear as mud, as staff and staff teams, either KHI or legislative research sitting here in the room as to where would be the best place to put this wording, and what should those words be? Senator Petty has a comment.
Yes, Senator Eddie. I know you mentioned, I'm looking under ease of implementation, and the second bullet, cost could be a barrier to implementation. And I'm just wondering if this addresses what you're talking about, just changing to say cost of implementation. could be a barrier. Because you're saying the implementation of the codes or cost of the change in the codes could be very.
Right, and you know, it's a good point, Senator. What I'm looking at is, you know, I'm trying to look at that, you know, look at our recommendations and stuff in a way legislators that are not familiar with how the Medicaid stuff works. And so they may, you know, they may not understand, okay, why does this have a cost? If all we're doing is adding language to our state plan to cover these. What does that mean? So that's why I'm thinking in the front and top end, because this clarifies that there will be a cost to the implementation, which is fine. But that opening codes may be also necessary.
So you think that there needs to be, I'm served on this work group, and I'm very supportive of early intervention. But my question is, do you think there needs to be some sort of work in the language under recommendation?
Additional language, not removing any existing language that's in there, but just adding the possibility of codes being used. And we may need to, you know, listen to the discussion between Gary and Deb. You know, do we need to, you know, clarify for people that those codes exist, that we just don't utilize? Because there's a lot of codes out there for a lot of things that we don't use in this. Whoever's got the solution, feel free to jump in.
Madam Chair, would it be helpful, this is Hina Shah from KHI, to in the recommendation language itself, in the second line, right, to explicitly cover the cost of early childhood?
I'm sorry, I couldn't hear where you were at.
I'm on page 24.
Yes.
And in that first box where it provides the recommendation language itself.
Yes.
In the second sentence, just add the word. So where it says additional language in the Medicaid state plan to explicitly cover, and add the two words, the cost of early childhood mental health.
I think that solves it. Everybody agree? Yep, that does it. So let's add that. And I'm going to make something clear. I just had a discussion with my legislative research folks. In order to maintain the integrity of the working groups, and so that individuals know where we were and where we're going, the changes that you see us tweaking on this today, because you won't see any major changes done, those will be identifiable in the final report, so that we know what where the working group came, and then where the legislative committee, where the final decision on the report, made their changes. So we'll be able to see that, because I don't want to downplay any of the work that was done by our working groups. And Melissa has a very good understanding of what I just explained. Okay, any other changes, comments, or questions on 4.2? All right, seeing none, we are on 4.3.
Fantastic, thank you. So the next one, 4.3, page 25, this is entitled Centralized Authority for Immediate Action. So I think the piece of this that I thought was interesting on the earlier discussion about a suicide prevention coordinator and some of the problems that the state is having coordinating efforts, and I think getting some synergy around some coordination when you have different departments and state agencies handling the same topic. I think this is also where this comes into play. And there's also some precedents, you know, in 2017, the federal government actually created what they called a mental health and substance use czar, because apparently there's 100 federal agencies that are concerned with mental health and substance use concerns. And there was some concerns about needing to overhaul some of the things that SAMHSA was doing. So they created this assistant secretary position, basically elevating the person in charge of SAMHSA to report more directly to the president and for some, you know, level of accountability. So that we didn't get into all those details in our work group, I will admit, but I think there's some parallel in terms of what we're looking for here. I think this recommendation could also be something somewhat of a legacy item. You know, this right now, there's a great deal of interest in mental health and substance use, and to make sure it's appropriately funded. I don't know that that interest is always sustained. I think other things tend to come to the forefront over time. And so perhaps institutionalizing some things might actually be a way of sustaining that as a priority going forward. So, but the central focus around this discussion was around prevention. And we do know that there are pots of money in different state agencies focused on prevention efforts. So I think I'm going to leave it there. Ease of implementation is 2, and it could benefit a large population.
All right, Representative Langford here. And I think this kind of tied into a discussion we had earlier today in one of our other groups about that coordination. Where should this all be placed? So this is good to come back in and reinforce that. Further comments, questions on 4.3? Seeing none, that puts us on to 4.4.
Yes, page 26. So this has to do with behavioral health prevention, and this is of strategic importance. And so really the discussion around this has to do with the fact that in a modernized mental health and SUD system, you're going to have more focus on prevention. And historically, Kansas has not really made that a priority. The federal government requires a percentage of the block grant to be spent on prevention. And historically, that's pretty much all that Kansas has spent. So our discussion really was that if we wanted to be modernized, that we would recognize the value and importance that prevention plays in helping to, you know, basically keep people from heading towards the cliff. We're so, you know, appropriately focused on people falling off the cliff and catching them and trying to intervene. But really, there's a lot we could do long before they get there, because data has certainly shown us what the indicators are for those folks. So this also calls out that we could certainly look at increasing the number of certified prevention specialists again in the state. These are folks that are highly trained in the science of prevention. There is a science, there is some great data that's come out over the last 30 years about, again, how to appropriately intervene and be successful and have positive outcomes with not only high-risk groups, but with the population. And so we used to have folks like that. And over time, the importance of that has waned. And there was contribution in our work group that suggests that we would like to go back to that. And then this also talks about the state suicide coordinator. I think that's it.
Comments, questions on 4.4? Seeing and hearing none, let's continue to 5.5, 5.1. That's a different group.
Madam Chair, this is Hina Shah from KHI. It's the same group, but now Gary Hinault will be presenting the vision and recommendations on treatment and recovery.
Thank you. This is Gary Hinault from KDADS. A modernized behavioral health system and expand an array of early, affordable, accessible, evidence-informed behavioral health services for all, with an emphasis being consumers that they are most likely to support effective engagement and treatment. Modernized treatment and recovery will include a data-driven, person-centered approach that improves health outcomes for persons served through access of evidence-based treatment and other promising practices, regardless of income and ability to pay. This system will include timely information exchange to support a meaningful coordination across settings. It would include schools, primary care providers, law enforcement, and the justice system. Additionally, early entry into the navigation of the behavioral health system should be clear and consistent. The working group also discussed the need to offer additional crisis services, including intensive outpatient programs, IOP, partial hospitalization, day programs, substance use disorder, family residential treatment, hospital and crisis beds. The system should have flexibility to adapt to the changing trends and needs in behavioral health indicators and service needs such as suicide rates, substance use trends, and pandemic impacts. So 5.1 relates to psychiatric residential treatment centers, treatment facilities, PRT. This recommendation was looked at as immediate action. It is a recommendation that there has been a lot of focus on over the last few years. The recommendation says that we want to monitor ongoing work to improve care delivery and expand capacity for PRTFs to meet the needs of youth whom our PRTF is medically appropriate, such as through the reduction of PRTF waitlist and focus of reintegration discharge planning, including the schools. This is a where over the past few years, KDADS, my team, and the Behavioral Health Commission has done a lot of work on. And I'd like to highlight just as we look at this, if we go back in 2019, July of 2019, we had over 209 children on the wait list. 40 plus of those were foster care. Currently, we are down to 7 on the wait list with 15 foster care. In addition to that reduction, part of what's happening reduction is an increased assessment and review, includes KDADS, the MCOs, and KDHE and DCF to review every child on the wait list to make sure that appropriate services are being offered before admission to PRTF. We've also worked to develop a medical necessity diet for admission and discharge criteria for PRTFs, which is now policy. And we have worked to identify providers for what we call specialty beds or specialty units. And we have, as of the first of this month, TLC has opened 50 new additional beds to help cover those children. KVC has restructured some of their beds, and we do have Ember Hope bringing on 12 additional beds. So we do have the bed capacity coming. The recommendation is more to continue monitoring this, that we don't, step back now that we've made a comment, but that we continue the monitoring, and that we also probably work more towards the regulations that are in process, a monitoring system that will better monitor the children on the wait list, where they're waiting for, what PRTFs are waiting for, who's done the assessments. But the continuing monitoring is needed to make sure that we don't go backwards in this process. This is an implementation score of 7, as it would require some overhaul in the sense of the monitoring. Cost. The cost of this is more related to the idea that we want to make sure that kids are receiving the services before they go into the PRTF. So there would be some increase in those services. That's less of an issue as we've made this a major focus. the idea of services when the child is discharged from the PRTF. We need to be thinking about children being discharged from a PRTF as a person being discharged basically from an ICU. It would have a pretty high impact, especially, I mean, in the population of youth that we are serving that have that higher acuity or that are in need of residential treatment. So with that, I'll stop and see if there's any questions.
Thank you, Gary. Reverend Carpenter.
Thank you, Madam Chair. Just clarification on how many people were on the wait list.
Currently, as of today, 107, 15 of those are foster care. That's up from about 3 weeks ago when we were down to about 84. So we have had a few, have had an increase in the last couple of weeks, but we've been around that 100 range for several. But the opening of the beds at as they are able to bring the staffing up, we should see a significant drop.
Yeah, I think we just had testimony yesterday that they brought on 50 beds up in the city, and so yeah, your microphone must have leaked out just when you said that. That wasn't what I heard out. So thank you.
Okay.
The testimony was 50 new beds up in the Johnson County area, and then getting closer to having the Amber Hope. And then
the Amber Hope, I talked with them yesterday, and they're thinking after the first of the year, they'll be starting admissions.
that's very exciting news. And then there's still a lot of work being done, the progress being up in the northwest corner of Kansas.
Yep.
Okay. Any other comments, Senator Pettit?
Thank you. I can't remember, we had a discussion, and I'm not sure if it's under this recommendation about access, about reimbursement for a provider to be able to just talk to the parents, not with the child present. Did we put that in any place? Is that in here? Because right now they can't receive reimbursement for just that. Isn't that correct?
Well, currently, when a child is in the PRTF, all the services are provided by the PRTF. So what I believe you're talking about is that there has been a lot of discussion around CMHC or our therapists being able to meet with families without the child while the child's in the PRTF. That is also that I think that issue is even bigger than that CMHCs and other providers are wanting to meet with parents without the child there, not when they're just in the PRTF, but at any time. I think that's the bigger discussion. But when they are in a PRTF, currently all services are provided by the PRTF, including family therapy and kind of therapy that the child would need.
This is Carly Houchin from KHI. If I could respond to part of your question there, Senator Petty.
Thank you.
I think the recommendation that you're referring to might be recommendation 9.5 related to family psychotherapy. And that talks about the procedure code 90846 that I think relates to the services you're describing there. So it is included as a high priority recommendation, but under a different topic and a different work group there.
Thank you.
Further questions, comments on 5.1? All right, seeing none, we're on 5.2.
5.2 is was put in as a strategic importance. The recommendation is to explore options to expand the behavioral health service array, including the expansion of medication-assisted treatment, MAT, services. Make the expansion of service array available to individuals across the state, such as CanCare enrollees, those with private insurance and the uninsured. This kind of goes along with the recommendation earlier. I believe it was 1.3. It also says in here that we built on the language from 3.2. So this is really more that we want to expand the services that are available. Currently, those services are not as available as needed throughout the state. Ease of implementation is at a 5. We feel it would have would benefit a large population, and I would open it up to some of my other work group members if they would like to add more to this.
This is Deb Stidham. I just wanted to add that I think a lot of the focus when we discuss MAT, medication-assisted treatment, focuses on the opioid use disorder population. And we are still seeing a very large population of alcohol use disorders to which these medications are highly effective. But we lack adequate funding for that, for the uninsured, to get them these medications. So I just wanted to call out that the other population that I think deserves some focus.
This is Representative Elizabeth Bishop. Madam Chair.
I recognize you, go right ahead.
Oh, thank you. I wanted to ask a question relative to the private insurance as I serve on the insurance committee. And I know we had legislation that I don't believe got out of committee. Not sure, but I don't think it did. Relative to private insurance and especially MAT and substance use disorders treatment, named after a young woman who was unsuccessful in getting a treatment through her private insurance. She found a placement where she could get treatment in Oklahoma, and the insurance company turned her down for traveling there, and she ended up overdosing. So I just was wondering about the connection with private insurers and how that would be accomplished.
Deb, I don't know if you have information that you would want to share about that. Or thoughts?
Well, I mean, this recommendation is a little bit more singular than probably Representative Bishop's. I think the genesis for that legislation, which I will say I'm not that familiar with, because what it sounds like to me is that particular person that the bill was named after had some difficulties with perhaps prior authorizations. I mean, clearly private insurance companies are still very loath to pay for hardly any inpatient stays. They don't tend to recognize certainly the kinds of community-based residential care. They consider that inpatient. So where a person might spend 14 to 20 days appropriately in a residential level of care, they see that as inpatient. They'll authorize 3 to 5 days, if at all. So clearly we do have some work to do on the private insurance side. Parity, the Mental Health Parity Act has had limited adoption, I would say, because there's not really a lot of enforcement, but that's to me a little broader than this specific recommendation. For me, we're overlooking a population of the indigent without access to any care. They might be block grant eligible. In fact, many times they are, but those funds are limited. And so the access to needed medications is not part of that service array. Again, for the alcohol use disorder population, we have some federal money in the state right now to help pay for these medications for the uninsured for opioid use disorder, which is fantastic. And our own Medicaid state plan has approved all those medications as well. So Kansas has a lot to, we've done a lot to help, but the uninsured continues to be the majority of the folks that we see. And they do not have access to these needed medications. And we don't know how long that federal money for the opioid use population will continue.
Thank you very much. Further questions?
This is Representative Elizabeth Bishop again. I'll just say that that was extremely enlightening, and obviously I need to have a conversation with Deb before going back into insurance committee work.
Thank you, Representative Bishop. Further questions? All right, seeing none, continue, please.
Okay, recommendation 5.3 is frontline capacity. This is also strategic importance. Increased capacity of frontline healthcare providers, basically pediatricians, family physicians, OBGYNs, to identify and provide services to those with behavioral health needs. This is an issue that comes up quite frequently, that most folks that are having some sort of mental health or behavioral health issue or SUD problem end up being seen by a medical provider or are seen by their family physician or their OBGYN for another issue. And then in the process of being treated, some other issues are identified, especially within children. When we look at children who have completed suicide, recent statistics show that almost every child who had completed suicide had been seen by a pediatrician or family practice doctor within 30 days of that. Most of them, a very small percentage, had been seen by a behavioral health provider. So it's important for us to make sure that these folks are armed with the information they need. They're not fearful of asking the questions or trying to get to what else is going on that could be presented as some of the physical issues that are come to be seen for, and gives them direction on where to go, what to do, and how to respond to this. KDHE does currently have 2 federal grants that are focused on this issue, and they do have programs that frontline medical staff can take part in. But this is something we feel needs to be expanded greatly so that we can make sure that we don't have medical providers not want to ask a question out of fear of them not knowing what to do if they get an answer that says that there's more going on. This is an implementation, ease of implementation of 5. It would require the expansion of the current programs. And existing programs are currently grant funded. So making long-term sustainability contingent upon additional funding streams such as Medicaid reimbursement. We also see it as an impact of 8, as it would benefit a large population. As I said earlier, the statistics show that, at least in children, most people will see medical help for a symptom or something that they're experiencing that really is more of a symptom of a behavior. And with that, I'll open it up for questions.
Any comments or questions on 5.3? Senator Petty.
Thank you, Mr. This is Senator Petty, and thank you, Madam Chairman. I just would say that I think that this recommendation really focuses on, as one of our prior ones did, on early intervention and the impact that can have on addressing early. We know that often, someone who's just had a child, if they have those early appointments, then they're really, that may be the only opportunity that you may have to have contact with them, and that can help with their mental health as well as that the environment for their children. So I think when we see that the high impact, I think an 8 is, this is probably even higher than that, but it can save us a lot of money in the long run.
Thank you. Further comments, questions? All right, ready for 5.4.
Okay, recommendation 5.4 is housing. We saw this as strategic importance. They wanted to expand the housing program and the SSI, SSDI outreach, access and recovery, SOAR, including additional training regarding youth benefits. The youth benefits are something I hear about quite often as I travel around the state and ask, do you have a youth SOAR worker? A lot of folks have not heard of youth SOAR, do not understand what it can do. What it can do, though, is help connect transition age youth to programs that they will need as they move into adulthood. A lot of these young people that are having issues that could benefit from SSI or SSDI have no real support making that happen. This can certainly help with that. And the housing programs are seen as just fundamentally one of the very basic concepts that we need to do that are having behavioral health needs. Housing is the foundation of security for people. So housing programs, affordable housing, services for low income, services for the homeless. We have several staff in our commission that get calls all the time related to folks who are just in dire need of these services. So expanding them, getting more training out there, getting more people trained, not only just in SOAR in general, expanding those housing programs is what this recommendation is about. We see that it would require some program change or overhaul, some federal approval process, regulatory processes, agency budget. So there is some issues in getting this taken care of. So the mailman just knocked on the door, so my puppy's gonna bark. It is a high because there's so many people in the way of an adult population that are struggling with services that this could help, and that transition age youth population certainly would benefit greatly from this service. So with that, I'll open it up for questions.
All right, committee questions, discussion on 5.4. All right, hearing none. Who's doing special populations?
This is Hina Shah from KHI. So the last topic for this work group is special populations, and I'd like to invite Kelly Ansari to present the vision and then followed by the recommendations.
Good afternoon, Madam Chair and Committee. My name is Kelly Hance-Reid. I'm the Director of Medicaid and Children's Mental Health for DCF. And today I'm going to be talking about special populations on page 30. So when we were discussing this, we had realized that there were a few populations of people who might require a unique perspective to serve them, and they might have additional sets of vulnerabilities that would make them susceptible to struggles or anything that would require, just looking at their treatment under a different lens. And so we thought to modernize a behavioral health system to really serve special populations in a way that is useful to them, it would require data, but also just feedback from these individuals and families in which are experiencing this to try to drive some of the innovations on what they need and what they would feel like would be useful to them. We thought building on strengths that are already there, because there are a lot of really great programs going on across the state that are helpful. So building off that, integrating them, and being responsive for when crises are identified by some of these populations. So talking about changes, it really educating individuals or different agencies, trainings, and just ultimately making sure that we're providing quality wraparound services that meet all of their behavioral health needs, especially when considering individuals who are experiencing co-occurring disorders. And so the variety of special populations that we discussed were quite a few, but some that kind of rose to the level of consideration are victims of domestic violence, children of incarcerated parents, individuals with a limited English proficiency, pregnant women experiencing perinatal mood and anxiety disorders, and others. So I will turn your attention to page 31, recommendation 6.1, for immediate action discussing domestic violence survivors. According to the CDC, 1 in 4 women and 1 in 10 men have experienced some form of intimate partner violence. And their children have experienced that as well. And so our recommendation is to build awareness and responsiveness to these unique behavioral health needs of survivors who've endured this, and really digging into some data, sharing data from different entities that do this work, training the workforce in these unique needs of this population, and really targeting interventions for domestic violence providers, different state agencies, and any other community agency that's providing these services. We thought the ease of implementation would be a 6, and the potential for high impact would be 8, just due to the prevalence of this, and then also how it could potentially be affecting their children as well. I will stand for questions.
Any comments, discussion on 6.1? Seeing none, we're ready for 6.2.
Thank you. So 6.2 on page 32 is parent peer support. So we talked about this as a great avenue due to the workforce shortage across the state. Parent peer support is a different modality to support parents who are trying to raise children who have unique challenges or behavioral health issues. Sometimes, a lot of times we talk about all the services we don't have and what we're lacking. But sometimes I think it's worth talking about what we have a lot of. And what we have a lot of in Kansas is parents, and parents who want to help other parents. And so parent peer support has found, evidence-based that can be effective for parents. And it's also a cost-effective strategy for improving outcomes for children and parents or their caregivers. So we would just like to increase access to parent peer support for caregivers and family of youth that are accessing behavioral health system, and ensuring appropriate supports for especially fathers of dependent children, not leaving them out. We thought the ease of implementation would be a 5, and the potential for high impact would be a 7, just due to how many children are involved in these systems and their caregivers who require or could just want to talk to someone else who has the lived experience that understands what they're going through. And this was for immediate action.
Committee discussion, question on 6.2. Senator Kirshen. I don't know why it is I'm struggling with your name. I should not. You don't like me. What did I say I didn't like?
Thank you, Madam Chair. Dan Kirshen, Senate District 26. I thought you did a really good job explaining all these the concept of what we're trying to do with the stuff we have and working to improve it. I noticed though from the ease of implementation from the 6.1, even clear back to 5.3, they're all the same. Cost of the program, new people, maybe an agency change. Those are big barriers, aren't they? It seems like there's a lot of them, so you have to prioritize which one of these you can do it one at a time or something. If you can hack all of that. It's a lot to take on with those amount of barriers. I'm not trying to discourage you, but you're outlining what you've done is really good. I like that part of it, but it's me like there's a lot more challenges ahead. With organization budgets, American implementation, workforce capacity, all of them are the same. It's a lot of sequences. Oh.
This is Gary Hinault from KDAD. I agree with you, but and most of the things we're looking at when we look at changes, we're looking at some program changes. And some of those can be done easier than others. Peer support is something that's out there and successful. Adding parent peer support, which is something that we've been trying to work on for a little while, is basically adding a change to that program, bringing the parents in. having spent before coming to the state 17 years in mental health centers and 20 plus years in inpatient psych units before that, the need for the support for these parents is huge. These parents have nowhere, and oftentimes because they've had significant interactions with providers that have not necessarily been overly positive, because it's just part of the struggle of serving people with children with behavioral health issues. Having that parent support person there, and a peer parent support even makes it of more benefit. But having those people there adds to this significantly. And a lot of times the struggle for the provider is how do I the parent on my team, the school on and working towards the better, something better for the child. So the parent peer support would be huge on that. But I agree with you. We do see program change in there because program change is something that happens with most of these. The cost gets in there because it would be a new billing. Parent peer support would be a new service that we'd have to bring in. So there is some cost to that, but the cost of that versus the benefit is huge.
I thank you, Gary. This is Kelly from DCF, and I would also like to add, they are very real barriers, but also it's almost an opportunity to some degree as well to create jobs for those who have these lived experiences. We have parents out there that are very well versed in what works for some children, or what services are out there, how you access those. And I think, that could be a nice opportunity to just create those additional jobs as well.
Thank you very much. Further comments or questions on 6.3? No, I'm sorry, we're on 6.2, 6.2. I might just make a comment. I think in this section here is one of the things that we should keep in mind as we progress forward is that, we're trying to look at today and tomorrow way out into the future. When I started this process, I talked to staff about being a 10-year plan, knowing that that's a big bite. But we have to start somewhere, and then we just start nipping away at things as we go forward. But we also have to keep in mind that this is not just a state issue. Our local units of government in our cities and our counties are going to have to be a part of this of a lot of these solutions. And I see that a lot in the 6.1 and the 6.2 as a classic example. And I know that some communities have started those discussions I know that like in Sedgwick County, our sheriff has been really involved in getting our community, finding out what resources that our community has, how do they communicate with each other, so that we can figure out a way for people to navigate all the services out there, whether it's a Catholic Charities or it's a community mental health center, or it's a Grace Med, which is our FQHC. There's a lot of, he's found a lot of services, but they don't connect. And so when a parent goes looking for this, they don't know what to do. It's like, who do I call? Where do I go? Schools may have some advice for them, and schools may not. So our communities have got to become involved in this, not only from a resource perspective, but there's also going to be a financial piece on them as well. This is not just a state issue, and it cannot be, nor should it ever be, whether it's in urban or it's in rural areas. It's just, rural may end up getting a little more assistance because of the tax bases that they deal with and stuff, and that's fine. We're good with that. We just got to make sure the services get to the individuals that we need to serve out there. And we're hoping that the younger we start this, that we start decreasing the need on the adult side of what we're dealing with here today. So just kind of
Madam Chair.
Yes.
This is Gary Hinault. I'd like to just tag on a little bit to what you were saying. When I first started with the state, and one of the things I asked to do was to visit every mental health center in the state of Kansas. I have now been to every mental health center in the state of Kansas at least 3 times. I found, especially in the more rural and frontier areas, that I found was very interesting is I would ask them questions, and the same question when I went to different places of how do you manage a child when you are in need in a psychiatric crisis or in need of hospitalization. The huge difference I found was in areas that did not necessarily have a hospital right close to them. We're making use of all of those community resources that you were talking about. And they were wrapping these children around and basically doing parent peer support and many other services that they were able to do, and their hospitalization rates were lower. And I really think that what we're talking about is bringing some consistency to that and bringing that what's been learned in areas that have had to do that forward and making it that we can offer across the state. A lot of times folks want to say the folks in the area have maybe something better or available to them, and I think we have things to learn going both directions.
Thank you, Gary. Further comments, discussion on 6.2? Seeing none, we're ready for 6.3.
So 6.3 on page 33 discusses crossover youth. So just our recommendation is to continue to develop linkages between the behavioral health system and the juvenile justice system and child welfare to increase understanding of the unique treatment options that are available or should be available to youth who are externalizing trauma, and they're showing that in a variety of different ways, that some of which could be exhibited in different types of illegal or delinquent behavior. But in that crossover youth population, understanding their treatment options and how to enhance those specialty services to meet the unique needs and challenges of this population. Although this is not a large number of children, they do have a large amount of resources invested in them by a variety of state agencies, because typically they're involved in a variety of state agencies. So, just trying to improve communication and information sharing between these, and addressing the gaps in services that still exist when it comes to treating these types of children. The ease of implementation score is a 4, and the potential for a high impact is 8, and that's due to it is a small number of children, but they are a resource intensive population. They utilize a high number of resources, and they're many times they're getting to be older and becoming adults, and then that just creates a whole nother involvement in different types of systems. So that's how we came up with that. And this is a strategic importance level.
Any comments, discussions on 6.3? Yeah, I believe that in your rationale discussion, a statement that's sticking out to me is, although not a large population, the working group highlighted the large amount of resources invested by multiple state agencies to currently support them. And I think that as we've gone through this process, and those that have been around these social services budgets for quite a few years, is that we know that that's and has been a problem. And so I hope that we can put a large focus on trying to, make that communication happen. And hopefully it's not something, Representative Carpenter, that is expensive to do, but then we can start getting that communication. Because again, it goes to, if we combine all the resources we have available, whether it's on a state level or in our local communities, we would find we can stretch those dollars so much further if we're all coordinating together. It doesn't mean anyone has to lose their anonymity at all, because that wouldn't be right to anybody. But we can make this happen. So I think that's a very good statement. Further comments or questions on 6.3? Seeing none, we're ready for 6.4.
Okay, I'm on page 34. 6.4 is IDD waiver expansion. And so this is to fully fund the IDD or intellectual and developmental disabilities waiver and expand IDD waiver services. Also increasing reimbursement rates for IDD services to support workforce expansion. I know that's a lot. So what we mean by that is what we're seeing is some difficulty with individuals who have IDD and many times co-occurring disorders, mental health disorders. And these individuals we're finding are having a hard time being served in the behavioral health system due to their IDD diagnosis. And in addition, families, caretakers, and these individuals are really having challenges finding qualified professionals to provide the waiver services. I'm sure you're all well aware of all those challenges, but we just wanted to highlight that the lack of available services or workforce to provide those services is really causing caretakers, individuals, parents, a lot of struggle. And it's even causing children, because caretakers, parents can't find available resources or waiver services to address their children's needs. Some of these children are coming into foster care thinking that they would get an additional level of supports, but unfortunately that's not necessarily true. And so just thinking about that in regards to ensuring that our workforce is extensive enough to be able to provide the IDD waiver services that are currently available, you know, and looking at those reimbursement rates to give those individuals who are providing the services a livable wage and a desire to want to work in that system. So our ease of implementation would be a 4, because of course it's going to be you know, challenging and would possibly require the federal approval process. But the impact would be a 7, because again, although it's not a very large population, for the population, it would be extremely impactful. And again, these are individuals, again, many times involved in different systems, resource utilization is high. So that's how we determine that. And I'm sorry, my dog is barking because someone came to my house. I'll stand for questions and comments now.
Questions, comments on 6.4, Representative Carpenter.
Thank you, Madam Chair. Committee, I might add that yesterday in Can Care Oversight Committee, I introduced, the committee will introduce a bill for a 5% increase in reimbursement rates for the IDD community this year. Last year we had it in the budget. It was allotted because of obviously our budget shortfalls and things like that, but we're going to try it again. Now that's just a small part of this recommendation that we are working towards a solution for this recommendation. So just thank you.
Any further comments, questions? Senator Cruz.
Thank you, Chair. Is that 5? That's what the 22 million you put in last year. Okay.
Yeah, that 22 million's had reductions had a major impact on these individuals. But those were priorities made by someone else. Further comments or questions? Senator Petty, I won't go into that discussion because I think that we probably get into an argument because I also know that every governor I've ever served under usually get across the board cuts. All right, now we're on to 6.5. Okay, last one from this this work group. I'm on page 35, recommendation 6.5, family treatment centers. So we're recommending increase in the number and capacity of designated substance use disorder treatment centers, as well as outpatient treatment programs across the state. This was a recommendation originally developed by the Governor's Substance Use Disorders Task Force. And we believe that expanding access to these family centers would allow more individuals to receive treatment
so it's a very hard choice for some parents to decide to either leave their children and get treatment or not. And that, that's a decision we don't want to have parents make. Ideally, in best case scenario is for the whole family is that mom or dad or whoever could take their children to a residential substance use disorder treatment center so the whole family can participate in treatment. And so that separation of parents and children, which causes damage to children, it doesn't have to be there. And parents can receive the treatment when they need it with their children. So what the ease of implementation would be 5, and the potential for high impact would be 5 as well.
Any comments or questions on 6.5?
This is Deb Stidham. I'd just like to add to that, we currently have several women's and children's SUD treatment centers in the state, and Kansas is actually very fortunate. Other states actually don't have that system the way we do. But I think there is limitations. I mean, the definition of what we traditionally see as caregivers has changed. And really, I see this as part of our prevention efforts as well. One of the things that we saw as the advantage of that is when you have women, for example, when they're, already involved with DCF or they're pregnant and they're giving birth, but they're, they've been under the influence, or maybe even the child was born under the influence. These folks can be sent to these places and that bonding can occur. And we know how important that is in terms of getting things kind of started off on the right foot. I've seen remarkable things happen when young women are able to take their babies with them to treatment. It's really a game changer in terms of their motivation and their outcomes and those kinds of things. So I just wanted to add how I saw this as a preventative measure in addition to an intervention one.
This is Madam Chairman, Gary Hinault. I just wanted to add to this too, and I have visited several of these centers myself also. And it's important to me from what I heard from them, to make sure that we're including, Deb's right. These centers are wonderful. I've had several of them tell me that, a couple of them tell me that they even had women who were pregnant come to the center before the birth of the baby, and they're able to have a better outcome on the birth and connect with the child after the birth. But the services that I heard them talking about also was services for family and dads. So that, we don't put any parent or family in the situation of choosing between continuing to keep their family together and the treatment that they need.
All right, further questions and for discussion on 6.5? All right, seeing none. Looks like we're ready for the System Capacity and Transformation Group.
That's correct, Madam Chair. This is Hina Shah from KHI. I'd like to invite Andrea Clark to present the first topic, which is data systems, to present the vision and the recommendations.
Good afternoon. As Hina said, my name is Andrea Clark. I'm the Veterans and CIT Program Coordinator at KDADS. And I'm here to address the work done by the System Capacity and Transformation Work Group. The first topic that we looked at was data systems. Our kind of value statement around data systems is that a modern behavioral health system requires seamless real-time data systems with multi-directional data sharing among behavioral health providers, other healthcare providers and systems, community organizations, social service providers, law enforcement, and payers. I think it's helpful to consider how a modern behavioral health data system functions really on 2 levels, a macro level and a micro level. A modern system really provides useful, easy to access and analyze information at a systems level so that stakeholders and decision makers can get really an accurate snapshot of the system and how it's functioning to able to direct resources and really look at policy change. And then at the micro level, also a modern system really provides for efficient and secure exchange of personal health information. And this really goes to help facilitate the best care possible. So with this in mind, the work group, we identified 4 recommendations for immediate action and then 1 for strategic importance. And I will start with a first recommendation, which concerns the state hospital electronic health record, and that can be found on page 36 of the report. The Kansas Department for Aging and Disability Services has issued a request for proposal for vendors to implement a new state hospital EHR. But our work group really wanted to make a recommendation that while initial funding has been authorized, to continue to support action around this, to make sure that this is a sustainable project and addresses any future challenges or technology issues. The work group also wanted to highlight the need that any adopted EHR would be interoperable with other state systems, particularly the need for the system to help facilitate quick reinstatement of Medicaid benefits after discharge from an institution. Given that there's an RFP in the works, we have an ease of implementation score of 9, and a potential for a high impact would be 9. It would greatly impact the state hospital population and the ability to improve continuity of care for those there. So, stand for questions or comments.
Questions, comments on 7.1? All right, seeing none, we're on 7.2.
Okay, so recommendation 7.2, which can be found on page 37, is regarding data and survey information. The work group really endorsed or recommends legislation that would return the process to an informed opt-out consent as opposed to improve meaningful data collection. The current process is requiring opt-in consent for surveys like the Kansas Communities That Care and the Youth Risk Behavior Surveillance System. The work group discussed how stakeholders believe that these opt-in requirements has resulted in a significant decrease in the number of surveys completed, and that this type of surveillance data is really essential to inform prevention and mitigation efforts, including school suicide prevention and mental health programs. The lack of data by this switch has also hindered the ability for the state to complete federal block grant requirements. So any questions or comments?
Questions or comments on 7.2? Not seeing any, we're ready for 7.3.
Okay. So 7.3, the recommendation, which can be found on page 38. The work group discussed utilizing Medicaid funding to incentivize participation in health information exchanges like KHIN or LACI. The work group believed that health information exchange can lead to better coordination of care, yet did not want to mandate participation in health information exchange for providers, and felt that incentives would be more effective to increase participation given the potential high initial cost for providers to implement and execute systems. So by utilizing the Medicaid program, for example, waiver amendments or other federal innovation models, these types of incentives, we chose to highlight them because other incentives haven't necessarily been historically available to behavioral health providers, and also federal funding from earlier programs has concluded. So we gave this an ease of implementation, let's see, score of 8 and a potential for high impact for 9, partly because of the large population it could potentially impact across the state.
All right, committee, questions or comments on 7.3? All right. Seeing none, 7.4.
Okay, So 7.4, which can be found on page 39. 7.4 is the work group recommendation to conduct a statewide needs assessment for substance use disorder in the state. This is a recommendation that was originally developed by the Substance Use Disorder Task Force. A needs assessment would examine funding and access to treatment across the state, as well as look at policies to encourage effective utilization, integration, and expansion of SUD treatment resources. The work group recommended that the needs assessment be conducted on an ongoing basis and that the system be continually reviewed. Ease of implementation score was a 7, and potential for high impact was also a 7. If there's any questions or comments?
Any discussion on 7.4? Seeing none, let's go to 7.5.
All right. So 7.5 was our work group's final recommendation around data systems. And this can, let's see. It's our recommendation of strategic importance. And this is the need for state agencies to develop policies that improve cross-agency data sharing and making service and program decisions based on shared needs assessment. This was a recommendation originally developed by the Prevention Subcommittee of the Governor's Behavioral Health Services Planning Council. And it's really about, again, underscoring the need to establish common goals across agencies, the ability to improve efficiency for those we serve, and really highlight gaps in care for those that are served by multiple agencies. So again, just another kind of underscore what some of the other work groups have discussed today in terms of, interagency and outside agency collaboration, and really the need to work across our walls. So I'll take any specific questions or comments.
Any further discussion on 7.5? All right, seeing none. Thank you. Now we're on to the interactions with legal system and law enforcement, and start with 8.1.
And I'll also be speaking towards this topic from the work group. So the interactions with the legal system and law enforcement. The vision of the work group was that a modern behavioral health system allows for timely connection to services for those in crisis, that is in the least restrictive setting, and continues to and is appropriate to ensure public safety. So a modern approach increases access to treatment resources for those that are in justice involved, and also provides training to law enforcement, courts, legal system to increase awareness of mental health issues, and provide tools for first responders to have the most appropriate response. So we identified in our work group 4 recommendations regarding the legal system and law enforcement. 3 we highlighted for immediate action, and 1 for strategic importance. And those recommendations, 8.1, begin on page 41. And that's a recommendation to expand into correctional facilities training that allows employees to better recognize substance use disorder and also have a trauma-informed approach. KDADS currently has some funding to provide law enforcement, first responders, and correctional employees at the local level training on mental health. And the work group really recognized the need to ensure that substance use disorder and trauma-informed response were included, and to expand that training across the state. Any questions or comments?
Questions on 8.1? Seeing none, let's hit 8.2.
Great. So 8.2, which begins on page 42. This was a new recommendation that our work group developed, and that was really wanting to recognize the significant work done by the Criminal Justice Reform Commission addressing behavioral health. The Criminal Justice Reform Commission's final report was released just at the beginning of the month. And specifically, our work group discussed supporting report recommendations around the expansion of pre and post-charge diversion programs for those with substance use disorder, as well as the support and expansion of specialty courts. As the document we are working on is a living document, the work group recommended developing a process to monitor the implementation and status of the recommendations made by the Reform Commission, and just continuing to align the work done by the criminal justice world and professions with the work being done here. So I will pause for questions on that recommendation or comments.
Questions or comments on 8.2? Seeing none, 8.3.
Okay. 8.3, this is our third work group recommendation. And that was around increasing the utilization of evidence-based substance use disorder referral for those with law enforcement contact. This was a recommendation originally developed by the Governor's Substance Use Disorder Task Force. And our work group really wanted to highlight the high incidence of substance use disorder among those with law enforcement contact. And again, discuss the importance of aligning our recommendations and efforts with the other work going on in the criminal justice professionals and law enforcement in the state, including the Reform Commission, the Criminal Justice Reform Commission I mentioned, as well as there was also a recently released pretrial justice task force report. One of the recommendations the work group wanted to highlight as a step that the behavioral health system side of things could really impact the intersection of law enforcement is the implementation of the CCBHC model. As one of the requirements for that model is the development of partnerships between behavioral health providers and law enforcement. So that was really a step that could be taken on the behavioral health side of things to improve interactions and improve the collaboration between law enforcement and the justice system and the behavioral health system. So,
Further comments or questions on 8.3? All right, 8.4.
Okay. And 8.4, lastly, and this is again just to build off of the I think the recommendations made by the work group addressing special populations. Our work group noted of strategic importance the recommendation that an operational definition of crossover youth includes behavioral health, and again just highlighting the need to have a clear definition for which youth that fall into that category of youth that fall into that category. And the addressing behavioral health needs is critical to serving those that are duly involved in juvenile justice and the child welfare systems. So again, a recommendation more related to strategic importance that has a high impact for probably a smaller population, but one that uses high resources across the system. So.
Any comments or questions on 8.4? Seeing none, thank you very much. We appreciate it.
Thank you.
System transformation.
Madam Chair, this is Hinesha. Kyle Kessler will be presenting the vision and recommendations for this topic.
Good afternoon, Madam Chair. This is Kyle Kessler, Executive Director of the Association of Community Mental Health Centers. Very much appreciated the opportunity to help co-chair this subcommittee or working group along with Andrea. Appreciate her work on presenting the previous recommendations. On system transformation, a modernized system will work both in evidence-based treatment and prevention with focus on patients to address a continuum of needs. Transformation will result in a mission-driven, rationally funded, and outcome-oriented system of providers that uses data as an asset to identify problems and develop solutions. Excuse me. An important strategy for system transformation will be addressing the continuum of care to ensure an integrated and coordinated approach to care delivery. The System Capacity and Transformation Working Group also discussed barriers related to cross-system collaboration, infrastructure changes, and Medicaid payment for services to families. Our recommendations include recommendation 9.1 relating to the regional model and recommends immediate action. Developing a regional model that would supplement the traditional state hospital setting with regionalized facilities accepting both voluntary and involuntary admissions for persons in acute systems or services, as well as longer-term tertiary specialized care. Currently, there's a particular gap in capacity in South Central Kansas. Again, as a reminder, this issue has been discussed probably for at least 3 years because of the significant transportation costs that are accrued from South Central Kansas to Osawatomie State Hospital and a lack of additional inpatient providers in that area. The rationale, a version of this recommendation was originally developed by the Mental Health Task Force. It was a standalone recommendation in the 2018 Mental Health Task Force report, and then consolidated into recommendation 1.1 and 1.2 in the 2019 Mental Health Task Force report. The working group discussed that while cost is a primary barrier to implementation, there are opportunities for cost savings by reducing the high cost of transporting individuals to Osawatomie State Hospital or Larned State Hospital, and both institutions are a significant distance from key population centers, particularly in the South Central region of the state. This recommendation could be implemented by a combined approach of state institution alternatives and smaller regional state facilities. Ease of implementation, I'll go ahead and get to that and the potential for high impact. Ease of implementation was seen to be an 8. Potential for high impact was a 9 because of the large population that could benefit, and also producing of cost savings via reduction in transportation costs. And I will stand for questions.
Questions or comments on 9.1? Senator Kirschner.
Thank you, Madam Chair. I'm glad this is in there. I know it's been talked about, but this, at least in our area and neighborhood, that's really a plus. We've been talking about it for several years. President Wago has had special meetings and lunch to talk about these things and how it could work. And it's something that really, I think, has a future. It may take a while, but it's I think the need is there and the will to do it. And a lot of good things that come out of that regional plan. So I just want to support that in our area. Thank you.
Any further comments or questions on 9.1?
Madam Chairman?
Yes.
This is Representative Elizabeth Bishop, and I have one small suggestion. It may or may not be appropriate depending on what kind of criteria we're using, but under key collaborators, I would suggest we add local governments.
What do the work group committee members say?
And this is Kyle. That was a significant part of our conversation, and recognizing that everyone from the sheriff's office to county, certainly CMHC in Sedgwick County is part of county government, but then even the surrounding areas, probably law enforcement, courts, Butler County, Sumner County, Kingman, potentially Harvey. So that would actually make quite a bit of sense in my mind, but I think that we have other working group members on and they may have other thoughts as well.
Other members?
And I would add that it fits with one of the comments that the chair made earlier. So many of these have local connections to them as well. And whether it's community mental health centers or non-CMHC SUD providers, a lot of local governments and county governments help to invest in the local health and human services structure. So that would be consistent with this recommendation, I think, as well.
Madam Chair, this is Sandra Berg with United.
Yes.
I agree with what Kyle's saying. I think the local governments, in particular, we heard from the law enforcement and the impact it has on them when they have to either transport or help support someone who has to travel a distance. And I think it would be a big impact on them. So I agree.
So maybe in looking at Reverend Bishop's recommendations, we do providers, local units of government, and law enforcement. Covered all. I'm getting some nods. So how's that sound, Representative Bishop?
Very good. Thank you.
You're welcome. That's it. All right, are there any further comments or discussions on 9.1? Seeing none, we're ready for 9.2.
Okay, thank you, Madam Chair. And then 9.2 in system transformation refers to long-term care access and reform, and the working group recommends immediate action. This is reforming nursing facilities for mental health, or NFMHs, to allow for the provision of active treatment and necessary rehabilitative services and crisis services in NFMHs and inclusion within the continuum of care. Increasing access to long-term care facilities, particularly for individuals with past involvement with the criminal justice system or those with a history of sexual violence. This is a new recommendation developed by the System Capacity and Transformation Working Group that updates language originally included in recommendation 4.1 from the Mental Health Task Force report to the Legislature in 2018. And the working group adopted this recommendation on NFMH reform to include new information on the need to increase access to long-term care facilities, particularly for individuals with a history of involvement with the criminal justice system. The working group described the status quo as one where individuals are often required to stay in acute hospitals because there is not a nursing facility with the capacity to care for them. At times, these individuals may be discharged from acute hospitals into homelessness, so the working group discussed the importance of supportive housing. For more information on this, please see recommendation 5.4. On under housing and increasing access to long-term care facilities could include discharging individuals currently in long-term care back to their communities. If appropriate, discharge planning occurs to connect individuals with supports available within the community. Further reformation of NFMHs could improve quality of care and discharge planning. This recommendation is a high priority to the working group due to the importance of protecting the rights of citizens by providing individuals with disabilities the opportunity to live and receive care in the least restrictive environment possible. The ease of implementation score was an 8. The potential for high impact was an 8. And I would stand for questions.
Any comments, questions on 9.2? Seeing none, let's go to 9.3.
Thank you, Madam Chair. Recommendation 9.3 on integration was also an immediate impact recommendation. The recommendation was to increase integration, linkage, collaboration, and identify care transition best practices among mental health, substance abuse, primary care, and emergency departments across the state. Adopt coding practices that allow for the integration of services across the continuum of care domains, including but not limited to primary care, substance use disorder, and mental health, to provide more integrated services to clients with co-occurring conditions. The rationale being that multiple previous collaborative efforts developed recommendations highlighting the importance of integration, including the Governor's Substance Use Disorders Task Force, Governor's Behavioral Health Services Planning Council, and the System Capacity and Transformation Working Group that built this recommendation from that work. And SAMHSA describes integration as the care that results from a practice team of primary care and behavioral health clinicians and other staff working with patients and families using a systematic and cost-effective approach to provide patient-centered care for a defined population. Integrated care can lead to better outcomes for patients as well as more streamlined care delivery. Adopting coding practices in support of the integration is seen as critical to the goal of providing best practice, whole person care. The ease of implementation score was a 6. And the potential for high impact was a 9, and percent impact or measuring impact, percent of number of certified CCBHCs in the state of Kansas, percent or number of counties served by mobile response and stabilization services, key collaborators being the legislature, CMHCs, FQHCs, and other safety net providers. So I know this conversation has come up across several different working groups, and certainly been a significant part of the CCBHC conversations that have occurred as well. So I will stand for questions.
Committee questions, comments on 9.3? All right, seeing none, let's deal with 9.4.
Okay, in system transformation recommendation 9.4, evidence-based practices was deemed of strategic importance. The recommendation is that Kansas should continue and expand support for use of evidence-based practices in the state, or EBPs, including for housing and supported employment, and coordinate EBP utilization across systems. For example, with law enforcement, substance use disorder, and mental health care, with the goal of implementing programs with fidelity when possible. The rationale: this is a new recommendation developed by the System Capacity and Transformation Working Group, and the working group discussed the delivery of evidence-based models or service as a key part of a modernized behavioral health system. With that in mind, the group also discussed the fidelity to these programs as originally designed, which can be challenging due to the variety of standards that exist between different EBPs. Regardless, the working group noted the importance of delivering evidence-based services throughout the behavioral health system, and in particular for those in long-term care settings. Ease of implementation score was a 6, and potential for high impact was an 8. And we get into the measuring impact, the percent of EBPs adopted by providers, and number of EBP programs funded, and appropriations. With that, I would stand for questions.
Any comment, questions, discussions on 9.4? Ready?
Okay, thank you, Madam Chair. System transformation recommendation 9.5, family psychotherapy is deemed of strategic importance. The recommendation is to enable utilization of procedure code 90846 in Medicaid as a tool to support youth in foster care, as well as any child accessing care in a PRTF. This was alluded to earlier in the policy and treatment working group as well. And this is a new recommendation developed by the System Capacity and Transformation Working Group related to recommendations from the 2018 and 2019 Mental Health Task Force reports to the legislature. This recommendation would allow for the provision of family therapy services without the child present. This was highlighted as important given that discussing the behavioral health needs of a child with a parent or guardian is an important part of care provision, and at times inappropriate in the presence of a child. The group also noted how the code could support the implementation of an evidence-based program called Generation Parent Management Training out of Oregon, or PMTO, which is an evidence-based structured intervention program designed to help strengthen families that has demonstrated positive outcomes throughout a 9-year follow-up period, including reductions in delinquency. The work group also noted that CMS has flagged this code as one with a high potential for fraud or abuse in some cases. The working group members were not overly concerned about the potential for fraud in Kansas, however, because the code was previously allowed under the CHIP program. When allowed in Kansas under CHIP, the code was not highly utilized, but utilization may be higher if allowed again due to implementation of the PMTO program. Ease of implementation was scored as a 10, potential for high impact as an 8. And I would stand for questions.
Any questions, discussion on 9.5? Senator Petty.
Thank you, Madam Chair. This is Senator Petty. This actually is the item I brought up earlier because I know it had been a discussion point in my action group. And it's been brought up in other committees that I've been serving on lately. I noticed, Kyle, that in here that CMS has flagged this as one for high potential for fraud or abuse. Do you have any follow-up as to why?
The fast answer to your question is no. I mean, it would be because without the client present, I think, and Dr. Berg or others could correct me if I'm wrong, but the thought that someone could bill and you wouldn't have a client present, then maybe that would ring up billing hours, but you still have somebody that you're talking to about that patient. And particularly for youth crossover youth is one example, or youth in foster care or in care of a family. I think that sometimes bringing up their problems in front of them can be triggering. And we know from states like Missouri and Texas, they have implemented this. And I actually inquired specifically about this, Senator Petty, and they had not heard any concerns from CMS. So I think there are some mixed messages, and I think Director Fertig has alluded to that before. And I think our Medicaid agency is really working to try and get to the bottom of that.
Kyle, this is Sandra with United. One of the issues that can occur is that if you aren't focusing on the family system, then it's easy to slide into parents' individual therapy needs or maybe a couple's individual therapy needs. And those folks are not covered, particularly under Medicaid. So that's where it gets a little, my word is squishy. But I think when you use it specifically in programs like PMTO, it shouldn't be an issue because that's very focused curriculum. That's a very focused intervention. So I don't think that would be an issue.
Thank you for that follow-up. To me, this seems to be a item that is very important for us to move forward on. When we look at the ease of implementation and the high impact it can have with the relationship with families with their children in need. Appreciate it.
Representative Landwehr here, I guess I'd have to ask, was following up with the last comment, is then would we want to do clarification in this for legislators to have the understanding as well as our agencies that we would only recommend that code if we were to implement the PMTO programs. Is that correct? Or is that not necessary?
This is Sandra with United. If we weren't to implement PMTO, is that what you're saying, Chair Landwehr?
Right. Do we make sure that we tie this code to the PMTOs?
Not necessarily, because there are instances like the reference to PRTF and the need for family therapy to happen independently of what's happening within the PRTF. So if we limit it to one intervention, we may lose out on another opportunity. I think the key here is oversight for the use of that code, just to make sure that it's being done appropriately.
All right, thank you. Further comments or questions on 9.5?
Chairwoman Landwehr?
Yes.
This is Rachel Marsh with the Children's Alliance of Kansas, and I just wanted to thank that working group for this recommendation and indicate our support for it. We see it more broadly than the PMTO issue, and also agree that the potential for any problems could be managed through effective oversight and regulations or policies around the use of the code. So thank you.
Any further comments or discussions on 9.4? Or excuse me, 9.5. All right, seeing that, thank you very much. I appreciate it. Next, we're on telehealth.
This is Hina Shah from KHI again. So I wanted to make sure everyone remembers that telehealth, that subgroup was made up of members from all three of the working groups, since this was a cross-cutting topic. It was also supplemented with a group of experts, and we do have a few of them on the line to respond to questions as needed as well. So Sandra Berg will be presenting the vision and also the recommendations for this topic area, but you may hear from other working group members as well as she goes through them to supplement their conversation as they were finalizing the report and ratifying it.
Thank you, Hannah, and good afternoon, committee members and chairwoman. The telehealth work group wanted to look and make sure that we had technology that was available in telehealth services to provide meaningful access to care across rural, frontier, and urban areas, that these services be high quality, integrated with other modes of care delivery, and ensure consumer choice and privacy. in addition to supporting the full spectrum of behavioral health care. So going to page 49 and 50, we came up with 5 recommendations. And as you can see on page 51, our first recommendation, 10.1, is rather lengthy around quality assurance. There was a lot of discussion around quality assurance to make sure that we were establishing consistent guidelines, measures for telehealth in collaboration with licensing and regulatory agencies, that we implement standard provider education and training, that we ensure privacy for our patients that are accessing services through telehealth, that we allow telehealth supervision hours to be consistently counted towards licensing requirements, and that we allow services to be provided flexibly when broadband access is limited. And that alludes to sometimes having to use a telephone instead of a video conference line. So due to the rapid expansion of telehealth services during COVID, the working group members highlighted a variety of needs to address and to ensure that high quality telehealth services are provided in Kansas beyond the pandemic. Relevant regulatory agencies and providers should develop guidelines for the provision of telehealth services that align with best practices. Those guidelines should recognize the value of consumer choice and provision of in-person services when needed or desired. We do not want telehealth services to replace, but we want them to be available to enhance. We feel like providers should be trained on any of the issues that could be related to telehealth through their existing professional organizations, that we continue to have telehealth resource centers, and that providers get continuing education. Excuse me, the privacy of patients is also paramount to protect their information when they're using telehealth, that they understand what the risks are, that there are platforms used that are secure, that there's technology that is compliant with state and federal statutes and regulations, including HIPAA and the 42 CFR Part 2, which covers the substance use. That providers are held accountable to educating the patients on these privacy-related issues, and they go beyond just the technology, not just telling people about the safety of the technology, but of people walking past them, you know, if they're in a session or having other people in the room with them, those types of things. One of the other discussion points was around behavioral health providers getting their supervision hours by way of telehealth. Currently, the expectation is that they're all done with a person-to-person, face-to-face encounter. The working group also indicated that video services are preferred and they should be high quality, but oftentimes that is not available. And so looking at what could be done through an audio only or telephonic. And then finally, that electronic health record utilization is critical, that it be able to support the delivery of telehealth services so that there is service coordination across the system. We did not measure the impact of this. We felt like there was more work that was needed before we designated an impact. So any questions, comments on 10.1?
Questions, comments on 10.1? I'm just wondering, reading through this, if we need to make note. And I think you're in that second, well, read the third paragraph, but right after rationale, where it starts with relevant regulatory agencies and providers should. Well, no, I guess that kind of clarifies it. I just want to make sure as legislators that as we proceed on telehealth services, that we visit with these different licensing groups, whether it's nurses or physicians or whatever, so that they can be working on incorporating, you know, whether it's rules and regs or whatever they have to do to make telehealth training a part of their CE hours or I don't want to make more, just more work, but so we make sure that they get the training. Do you think that that clarifies it well enough for us to go forward with this, or do we need to make mention? Senator Petty?
This is Senator Petty. Madam Chair, does that next paragraph address what you were asking? Or? Is that relevant regulatory agencies?
No, I think you're right that it does. I'm looking at something, it's almost like a beacon that says, when we do this, make sure that we're hitting that. I love the detailed explanation in here. I just don't want us to overlook that. Well, but the key collaborators is a really big clue too. So I think you're right.
I would say that we're probably in a better place now, considering what's happened in the last 9 months, and how providers have had to move exponentially fast into this arena and in all parts of our state. So I think they probably have a lot more information than they might have had.
Well, I think it's, as I said yesterday in our Arcane Care Oversight, is that there's a lot of negatives that go with this pandemic, but there's positives that are coming out of them. And I think moving to telehealth medicine forward is a big piece of this. Okay, ignore my question. Representative Carpenter.
Thank you, Madam Chair. And I agree. And I think this is great technology and has a lot of potential. I am still concerned with us getting up to speed with the privacy issues and HIPAA and that kind of stuff. I'm not an IT person, so I have no idea how easy it is to hack these video conferences. But when you're talking about mental health and sessions and stuff like that with psychiatrists and whomever, it does scare the hell out of me to think that someone could hack in there, grab that sound bite, video, whatever. I'm sure we're going to catch up with this kind of stuff, but I never underestimate those crooks. People call them scammers. I call them crooks. They're common criminals, and their ability to do this kind of stuff. So anyway, that's just mine.
Well, and I might comment on that a little bit. Representative Carpenter, it is frightening, but I can tell you that every day you would be amazed at the business that's done with, a lot of private financial bank, the whole yards that people are working with back and forth with the video. And it takes some, pretty sophisticated equipment to make sure that that's, guarded. But, I think anything can probably be hit sometime or another, but it's a concern to keep at the top of the mind. Everybody.
Nice way to be. I agree with that. In fact, when we had, when I was seeing my health, and we give our top issue, there were lots of issues important, but this was a top issue for me because, telemedicine could be a lifesaver for people in small rural areas that you don't want everybody to know your business. But if it's not secure, it doesn't do anything. And right now, I can't think of anything that's really secure because it seems like every day somebody will do something, or the target account or your credit card was at risk, and you think you're secure. It just goes. I got a thing from the bank the other day that that someone was trying to get into my bank account. Somebody stole the mail out of the mailbox. I mean, it just sounds like it's so silly, but the privacy of stuff that you have out there, and mental health is one of those issues that still have that stigma attached, and that people are still very weary to go help people, maybe even crazy to go get help. And then you say, okay, telemedicine will help you. And then somebody, they me, we would like to make it as secure as we possibly can. So people hesitate to come up, but all they have to do is hear somebody from company.
Well, and just to reiterate, that was hammered and hammered and hammered time after time. In the whole discussions on telehealth with, in our work group. Did you have something, Representative Lynn?
Yes, thank you, Madam Chair. This is Representative Lynn. I don't know if I missed it or if it wasn't discussed. Is there a time when some of these telehealth sessions are recorded versus just not recorded? And if they are recorded, how those are saved?
I think that question got brought up somewhere in our discussion, but I don't remember the specifics. Does someone on that committee recall that?
This is Sandra Berg with United. I know that was part of the discussion. There are times when sessions are recorded for training purposes. However, there is a lot of informed consent and permission given around those recordings. There's also rules around how those recordings are stored. So I would open it up to other committee members that have more knowledge around it than I do, but I know that that was part of the discussion.
Hello, this is Shauna Wright with the KU Center for Telemedicine, and your memory is right, Sandra. Typically, we don't record our in-person sessions, so we do not recommend recording telehealth, telemedicine appointments with patients, clients, or consumers. Sometimes for training purposes, we record sessions or appointments. However, like Sandra said, we have a lot of informed consent around that. Patients need to be informed. Their caregivers, if it's a child, needs to be informed. And there's a process for that, both for in-person recording as well as through telemedicine and telehealth. And again, where those records are stored and how they're encrypted, we have guidelines around that. But in general, we do not record sessions. And as a part of informed consent, we should be encouraging our patients and clients, particularly those in the teen years, not to record on their end either. So that's a part of just informed consent in general, but it is not standard practice to record an appointment or a session.
Thank you, Madam Chair. Representative Lynn again. I know when it comes to the criminal justice system, those sort of sessions would be recorded. So this is maybe something they're already doing. When you're dealing with like a child who's having to testify for child abuse or something of the sort.
But I think that goes into another area, not into the telehealth.
Service delivery.
Yeah, there you go.
Thank you.
All right. Any further discussion, comments? Seeing none. Let's see. We've got there. Okay, I'm going to kind of skip a little bit in here because we had one of the members that were on this committee. And was this Monday? No, this was Tuesday that they met, and there was discussions on, I believe it was origination codes, etc. So I'm going to jump forward, and I need Hannah to tell me which one that was in, and the working group members, and I believe it was Blue Cross and Blue Shield, and maybe one or two that were going to help come up with language. Can you get me to that? Because I think Sunny has to jump off for another meeting.
So Madam Chair, this is Hina Shah from KHI. We are on recommendation 10.2 reimbursement codes, which is exactly what you recollected. And Sunny Mickle is on the line as well. And Sandra can go through the recommendation and then Sunny can add to it.
All right, thank you. I didn't remember which one it was. I just wanted to make sure we got it addressed. I couldn't find it fast enough, so thank you. So go ahead and introduce the 10.2 and then we'll have the language change.
Okay, so 10.2 is about the reimbursement codes, and this is for immediate action. And the recommendation was to maintain reimbursement codes that were added during the public health emergency for telebehavioral health services, and consider options to prevent loss of facility fees so that providers are not losing revenue by delivering telehealth services. The rationale behind this was it's a new recommendation by the telehealth subgroup in consultation with supplemental experts. While many behavioral health services could be provided via telehealth prior to the pandemic, additional codes were added. For example, the STD waiver services, crisis intervention, tobacco cessation, where some have become eligible for reimbursement during the PHE. Working group members indicated that some of these services should be maintained after the public health emergency ends, though the changes were initially intended to be temporary. Additionally, the PHE has led to an expansion of the types of sites where patients can receive care, including at home. Services provided to patients in their homes are not eligible for a facility fee payment for the originating site. In situations where support such as IT, patient education, and preparation is provided to patients receiving the telehealth services in their home, commensurate compensation should be made available to service providers. And I will turn it over to Suni to expand on that.
Hi there. Thank you so much. This is Sunny Mickle with Blue Cross and Blue Shield of Kansas. And when the Policy and Treatment Work Group was taking a look at this recommendation, I noticed it and was a little concerned because I believe it creates a situation that discourages providers from continuing in-person services for behavioral health treatments. We want to incentivize providers, of course, to provide telebehavioral health services, but to pay them at a level that's higher than providers who are doing in-person services creates a situation after the pandemic where we could see providers actually leaving the local communities, maybe moving out of the rural areas. And we don't want to do that. We've worked so hard to try to encourage them to actually be available on site in their local communities. So what we were talking about a little bit at that work group meeting was to modify this language so that we take a better look at just what the potential impact could be from this. And I was making a suggestion to add a few sentences to the end of this recommendation at 10.2, specifically to make sure that we're going to give consideration to the feasibility of providing additional reimbursement for providers who actually are providing these technical support systems and any other assistance from patients who are receiving telehealth in their homes. And to provide the committee with a little more background, I want to make sure you understand what the facility fee payment typically is for. The facility fee payment compensates a facility for the use of a patient exam room, medical grade telemedicine equipment, secure high-speed internet, and for medical or behavioral health staff to actually set the equipment up in the patient exam room. So they're doing this in person with the patient. And we understand that for telemedicine services and telehealth services with behavioral health, there's some complication perhaps the first time or two that someone is working and doing this. But over time, it's not something that is going to require that same intensity of support. And to immediately add the facility fee in every single time that someone is receiving a service in their home actually it disincentivizes providers really from providing those in-person services that they do today. So I really would encourage the consideration for additional language. And I don't know if you want me to walk through that language today or if I should send that in to you. What works best?
Sonny, what you might do is, we've got some pretty fast typers here, but if you want to go ahead and read the language and where you would insert that, and then let's make sure that KHI gets it and, or let us say the research staff. So then it would be added into what we will see tomorrow. So it's
Certainly. Thank you, Chairwoman Landwehr. I'm proposing to add this language after the last sentence that's in the recommendation. So the last sentence begins with services provided to patients in their homes do not receive a facility fee payment. And that at the end of that sentence, I'm proposing to add the following. Consideration should be given to the feasibility of providing additional reimbursement for providers who furnish technical support for patients who receive telehealth services in their homes. However, further study and consideration should be given to the unintended consequences of mandating payments to providers in excess of in-person mental health visits. The committee would not want to encourage telemedicine in a manner that would incentivize providers to leave their community practices, especially in rural and underserved areas, or otherwise reduce their availability for the delivery of in-person care. In addition, if this proposal for additional telemedicine provider payments is applicable beyond the Medicaid program, it likely qualifies as a provider or benefit mandate requiring the production of a cost-benefit analysis and the test track of the proposed new charges on the state employees health plan, as required by KSA 40-2248 through 40-2249A. And that's the end of my suggested language.
Okay, and I appreciate that, Sonny, and I think that I found an email that you forwarded to me. So I'm going to make sure that staff has that. And if we can make sure that we go ahead and send that over to KHI, and we'll make sure that staff, just so that we make sure that they have that. And then we'll get it reviewed. But tomorrow, all these little changes and things that we've made today is when we will see them all in the one big report. And then that's what we'll decide to advance. So I appreciate you hanging with us today. Committee, are there questions or discussion on what Sonny was talking about?
This is Shauna Wright from the Center for Telemedicine. May I ask Sonny a question?
Sure.
And first, I'd like to say that we agree with everything that she said there. We don't want to incentivize telehealth to the point where we are de-incentivizing in-person treatment. And I agree with everything that you said there, Sonny. I was hoping before you go, you could help us understand. We have heard from providers, really more medical providers than behavioral health. And again, I think the billing gets confused. One, because there's so much terminology around telehealth billing, distant site, originating site. However, also during the pandemic, CMS said, if you're billing for a CMS service, you can continue to use your original place of service. So whether that's a community mental health center, private practice, hospital, instead of using the O2 for telehealth, you can continue to use that. And I think some of the conversation wasn't even necessarily around the originating site fee being paid if you're supporting a service in the home, but not losing the fee that you might have for being a community mental health center or for being an independent practice. If we're putting energies into virtually rooming a patient, scheduling, if we're still investing, even though the space isn't there, the technology time, the education, the virtual rooming, the crisis management. So I was wondering if you could help us understand. I'll just give you a quick example. I had a specialist provider tell me that she could no longer engage with telehealth because the fees were so much lower. But my understanding was that the physician fee was the same, and what might not have been captured were some of the other fees that might have been captured if she had went ahead and billed with her brick and mortar place of service. And I'll tell you, I don't understand all of that, but I think that's some of the push and pull, not necessarily changing the originating site fee. I agree with you on that, but could you help us understand that before you have to go?
Oh, certainly. That's an excellent question. And I can't speak for other carriers and other insurance companies, but I can tell you that Blue Cross and Blue Shield of Kansas, that serves 103 counties in Kansas, excluding Johnson and Wyandotte, is offering a payment parity today during the public health emergency for its private pay commercial market members that are fully insured. And in that situation, we are paying the same and not reducing that amount if the O2 modifier is being used. We encourage the O2 modifier to be used, though, in the private sector, at least for Blue Cross of Kansas, so we can accurately record and determine what service is really being performed. We understand that this is a different time and that some providers, it's not even safe for them to open their offices and see people in person. And that's why we're paying that amount during the public health emergency. But we're hoping that one day we can resume to a normal life and be able to get people back in the office and those providers as well. And we don't want to put people in a situation then that makes it more lucrative really for them not to open the office and to only see people from their, with the patients at home. Also, we still have other offices that are still open today. And when they're billing that facility fee, it's allowing them to engage with a member of ours that is located perhaps in a rural community. It reimburses that other facility that is opening up their doors, having staff work with that patient. So we're really trying to make sure that the facility fee stays what it's meant to be. And this is not about reducing payment, but I can't speak of other providers or other insurance companies are paying less during this public health emergency for telemedicine services. That's not something we're doing. And we've actually extended our telemedicine benefits to all provider types, not just the provider types we've always paid for, which are behavioral health professionals, as well as MDs, DOs, PAs, and APRNs. We've extended all of this through 3/31 of 2021. So we are still doing that. And that's in anticipation too, that the public health emergency will continue beyond January of next year. Thank you.
Does that help answer your question?
It does. And I also want to reiterate that the idea of doing that cost benefit analysis, we would much rather rates be determined on actual costs. And as much as we support availability of telehealth to all of consumers who may benefit from that, whether that's because of geography or special health need, we don't want to incentivize telehealth beyond in-person care.
Thank you. Any further comments on 10.2? I know it's just been very difficult. We've just been trying to get this worked out, and staff will make sure that we may even be able to provide you the wording of that this afternoon before we leave, just to show you what that language was, maybe print it out on something separate. Any further questions or comments on 10.2?
Madam Chair, this is Kyle Kessler.
Yes.
And I, based on quickly looking at this and visiting some with Sunny and others, I think that this recommendation makes quite a bit of sense in terms of the newer wording, and something that we haven't talked an awful lot about, at least in our working group. And I think through the course of I think I counted, we would end up with 40 meetings or 40 days worth of meetings with this committee and the subgroups and working groups after this is all done. And there's just a variety of different payer sources for behavioral health. And that ranges from commercial insurance to Medicaid to private pay to unreimbursed, which then ends up falling on states and counties or other local funding sources. And certainly, just to give some kudos during this, I think Blue Cross Blue Shield of Kansas has been a very good partner and a good steward for the people they cover in working with behavioral health providers during this pandemic. But it also then takes us back to the Medicaid conversation to mix potentially apples and oranges in how Medicaid works versus, and I alluded to this morning, so I'm a bit redundant, but we haven't seen rate increases for 10 years in Medicaid. So this is a population that's very vulnerable for sure. But whereas we can use commercial insurance and they're looking at real-time utilization and checking to see what kind of fraud may or may not be occurring. And I don't think that they've seen much, to my knowledge, on this. So that's a significant, this is, as you said earlier, Madam Chair, we've had an awful lot of clouds during the pandemic, but there have been some silver linings here and there that created some learning opportunities, and telehealth policy and payment processes have certainly been part of that. Thank you.
Further discussions or comments on 10.2? So the only change we have to that is the additional language that Sunny just provided. So now we'll do 10.3.
Okay, we're on page 53, telehealth for crisis services. This is for immediate action. The recommendation is to establish coverage for telehealth for crisis services to allow for the use of telehealth with law enforcement and mobile crisis services. We want to explore virtual co-responder models for law enforcement to aid police departments and other law enforcement agencies as they respond to mental health crisis in rural and frontier communities. I might want to add there, not just rural and frontier communities, but I think this would be beneficial also in the urban areas. The rationale behind this recommendation is to create immediate access to services in areas where providers are not physically located. The working group members highlighted a specific need for crisis services to be provided via telehealth, particularly in rural and frontier areas where these services are less likely to be available currently. Covering telehealth for crisis services could also support police departments or law enforcement agencies who frequently respond to behavioral health crisis, such as through the co-responder models that pair law enforcement with remote clinicians. Some neighboring states have already implemented co-responder models, which have the potential to generate savings by reducing arrests, jail admissions, and hospital stays. Related to the measures indicated in the measuring impact field below, the group noted that many individuals in crisis will not be Medicaid beneficiaries, so additional measures should be developed to capture the impact of this recommendation. Any questions or comments?
Questions? Comment? Continue, please. And part 4.
10.4, the originating and distant sites. This ties into a little bit on 10.2. The following items should be addressed to ensure that individuals receive and providers offer telehealth in the most appropriate locations. The recommendation is to adopt a broad definition of originating site consistent with the Kansas Telemedicine Act. It would also allow staff to provide services from homes or other non-clinical sites if a patient privacy and the safety standards can be met. And also to examine issues related to providers practicing, patients receiving service across state lines, such as exploring participation in interstate licensure compacts. The rationale behind this recommendation was developed by the telehealth subgroup in consultation with some supplemental experts. The issues were related to where providers can offer care, where patients can receive care in order for high quality telehealth services to be provided and give flexibility to patients. The definition of originating sites included in the Kansas Telemedicine Act is a site at which a patient is located at the time healthcare services are provided by means of telemedicine. Prior to the COVID-19 pandemic, allowing originating sites were limited by some insurers, preventing patients from receiving care in places like their homes. Adopting a broad definition of originating site would ensure that patients can receive care in a wider variety of settings if those settings meet patient privacy and safety standards. Distant sites, the location from which a provider offers care, could also be expanded to allow providers to offer services from their home and other non-clinical sites if patient privacy and safety standards can be met. Allowing providers to offer services in flexible locations can help address workforce issues by increasing access to providers in areas of states where there are shortages. The location of patients when telehealth is provided can be complicated by state lines. This could include scenarios in which a patient needs care while traveling or residing outside of their home state, such as if someone goes to college in another state, but they have a mental health provider in Kansas. The state in which the patient is located typically determines the criteria for licensure. In Kansas, providers who want to continue to offer services to their patient outside of the state must contact the licensing body in the state the patient is in order to provide the service. Often licensing bodies want to ensure that providers can connect patients to local service or crisis resources if needed, and other states may have options for temporary licensure. Exploring Kansas participation in interstate licensure compacts could address some of these issues. Additionally, since the onset of COVID-19, multiple out-of-state providers have expressed interest in providing virtual-only services to Kansas residents. While these providers could potentially address access issues, they could result in reduced care coordination with in-state providers. Issues related to practicing and receiving the services across state lines will need to be addressed as telehealth continues to evolve and grow.
Questions, comments on 10.4? Representative Valley.
Thank you, Madam Chair. This was really a very interesting discussion, especially in the rationale of the location of patients that could be in Kansas, but yet maybe you not be able to deliver services to people in Oklahoma because you may not be licensed in Oklahoma. And we were just discussing all of these, but you just have to know it's there, but you can work it out. I mean, you can say that so-and-so will be there at that time and you're doing it and actually you're covered. But I think up until we had this meeting, I didn't realize that that would be the case. And yet, if you don't get it covered, then the consumer is a person that may not be able to deliver your services, or you're providing the service, but you can't get paid, you know, and all of that. So it's, this was one of those good benefits that it comes out and we talk about it, and now everyone's aware of what the procedure is, and you're not delivering services, but not being able to. So, thank you.
Further questions or comments on 10.4? All right, 10.5.
The last recommendation from the telehealth work group was on child welfare system and telehealth, and this is a strategic importance recommendation. The recommendation is to utilize telehealth to maintain service and provider continuity as children, particularly foster care children, move around the state, to consider how the unique needs of parents of children in the welfare system can be met via telehealth. This recommendation that was developed by the telehealth work group was exploratory in nature and wanted to further develop and assess how telehealth can be used as a tool to provide consistent, high-quality behavioral health care services for individuals who interact with the child welfare system. What we see oftentimes are children who are moving placement to placement out of different catchment areas. They move in and out of different providers, and many times they get lost in the system or don't get restarted once they get moved again. But if we're using telehealth, it may provide more stable and continuity of care for foster care children. Once they develop a relationship with a specific provider, it also allows them to continue with that provider that they can trust and develop. Additionally, parents of children in the foster care children have consistency as well, and they can resolve some of their reunification issues to get their children back in the home if they have that availability and consistency across providers as well.
Questions, comments on 10.5? Right, seeing none, thank you very much. So that completes us going through each one of those items. Anna, did you have anything else that we needed to cover? We are going to go back to, I'll mention that the staff just handed out the language that Sunny gave, so you can see what that wording is, and we're going to make sure that KHI gets it so it can be disseminated to the working group members. We will go back and revisers got information on the CSU CIC issue, and then we've got minutes to do. So Hannah, did you have anything else that we needed to cover with everyone today?
This is Hina Shaw from KHI. That concludes the working group's report, so we have nothing further.
I know that we've had several members, talk about this, but I just appreciate the work between our revisor's office, our research department, and KHI in bringing this together and making this complicated process a lot more simple, but very productive, and that we couldn't have done it without all of the members scattered across the state of Kansas from the private sector that are actually out there doing this work, seeing these problems and seeing these concerns, and then the legislators that have participated on this committee, as well as attending the work groups, and sometimes more than one work group at a time. So we appreciate everything you've done. Now, our meetings are not done. We've got tomorrow to take it over and finalize some more things, but this was a start for us. So I cannot thank enough to make sure that Bob St. Peter and everyone behind the scenes, Carly and Hannah, you've been dealing with all of us and have had to do some additional meetings, besides just the work groups and with us. So we thank everything that you've done.
Thank you, Madam Chair.
All right, committee, we're going to have all right, so we're going to have the revisor go over the CSU issue we had and the CIC issue for the statutory language.
Thank you, Madam Chair. So I was asked to provide statutory definitions for the CICs and the CSUs. And if you recall yesterday when I said that sometimes you can define a term specifically for that purpose, we have on the books two definitions for the crisis intervention centers. One's for a juvenile use and the other is for an adult use. So under KSA 65-536, a juvenile crisis intervention center is a facility that provides short-term observation, assessment, treatment, and case planning and referral for any juvenile who is experiencing a mental health crisis and is likely to cause harm to self or others. And then under KSA 59-29CO2, a crisis intervention center in the adult context means any entity licensed by the Kansas Department for Aging and Disability Services that is open 24 hours a day, 365 days a year, equipped to serve voluntary and involuntary individuals in crisis due to mental illness, substance abuse, or a co-occurring condition, and that uses certified peer specialists. When I went to look for a definition for a crisis stabilization unit, I was much less successful looking for a statutory definition. Looking federally and across the United States, I only found a couple of definitions and they differed widely. And doing some secondary source research, I kind of understand why that is. I found an article from the Journal of Mental Health and Clinical Psychology that defines crisis stabilization services, and they call it crisis stabilization services direct services that assist with de-escalating the severity of a person's level of distress and or need for urgent care associated with a substance use or a mental health disorder. Crisis stabilization services are designed to prevent or ameliorate a behavioral health crisis and or reduce acute symptoms of mental illness by providing continuous 24-hour observation and supervision for persons who do not require inpatient services. Short-term crisis residential stabilization services include a range of community-based resources that can meet the needs of an individual with an acute psychiatric crisis and provide a safe environment for care and recovery. But what I found interesting is that they have a number of different models. There's a 24-hour crisis stabilization model, a living room model, crisis stabilization center. So there's a number of different models, which makes it legitimately difficult to define what a crisis stabilization center is, because it kind of depends on what model the state's using. What I did find commonality about is that it is short term. It's meant to be, approximately a week-ish. And it's meant to be much less restrictive than hospitalization. The crisis intervention centers are longer term, but still short term, less than 30 days. And they can be that intermediate step before someone is, it can be a civil commitment before someone is, I'm trying to think of the correct phrase. It can be a civil commitment before a longer term civil commitment.
So we have a statute, we have defined those in
We have
the
to find
statute,
the CICs, but
not the CSU, so maybe something we need to look at.
And I can send out the article that I have, as well as the definitions, if you would like. I can get them to research and they can.
I think you give it to research and we'll see where we end up, because it's not something we're going to just to add into this report at this time, but I appreciate that information. Thank you. Okay, Representative Bishop, I believe, had a comment or a question.
Thank you, Madam Chairman. This is Representative Elizabeth Bishop. I had a quick question about the last section that we were talking about, telehealth. And I believe that I was surprised to see that it wasn't covered under the telehealth section. And I think that's probably because it may be found somewhere else. And that has to do with telehealth hours or services that are provided by a mental health professional who would like to log that service, those hours, in terms of certification. And I was thinking that we had included that somewhere. It may have been under the workforce development area, but I'll just ask for clarification on that, and tomorrow would be fine for that.
This is Sandra with United, and Representative Bishop, it was addressed, I believe. It was addressed, I remember talking about it. It might have been in 10.1.
I'll take a look and see if that satisfies my curiosity. Thank you, Sandra.
Yeah, it is. It's in 10.1. It's 1, 2, 3, 4, 5 paragraphs down.
Thank you.
You're welcome.
Thanks very much. The other thing that I would just like to mention on the research between the different definitions of crisis intervention centers is I would like for the research to reflect whether there's any correlation with how the services are funded. I doubt it, but there may be some, and I would like to see that included with the research. Thank you.
Any further questions or comments? Oh, Representative Carpenter.
Thank you, Madam Chair. I was told that the difference between the crisis intervention centers was that the ones that ks are licensing is that they're voluntary versus involuntary. They can take both, and the other ones do not take involuntary.
Right. So we may want to visit with our professionals on this issue, just because we define one statute, but we don't define the other. And do we need to make that definition? All right. Is there any other business that we need to cover today? Oh, the minutes. Representative Bell.
Thank you, Madam Chair. I'd like to move approval of our October 30th meeting of the Special Committee on Kansas Mental Health Modernization and Reform.
Motion made by Representative Ballard to adopt amendment, seconded by Representative.
Second, Carolyn Megan.
What?
Oh, I was seconding it. Is there already a second?
Oh, seconded by Senator McGinn.
Thank you.
Questions, comments? All right, seeing none, all those in favor signify by saying aye.
Aye.
Opposed? Ayes appear to have it, ayes do have it, motion carries. All right, committee, we are adjourned until 9 o'clock tomorrow morning.